to be at the same time and to have a lot of discussion and controversy, because it is a key to be useful in this webinar. John?
Giuseppe. Perfect. Giuseppe, thank you so much. What a pleasure to participate and help with this webinar with you. We're really fortunate. We have a world-class faculty from around the world to be able to share with us their thoughts on controversies in shoulder arthroplasty. The meeting itself wouldn't be possible without the generous support of our sponsors that you can see there to help support this educational effort, and also to make it free. So we have the chance for participants from around the world to learn from these experts in shoulder arthroplasty. One of the things that we would really like today is to make this interactive, so please feel free to add your questions in the chat box as we move along with that. I think that's important. We'll also try to keep the webinar on time. We value everyone's time, so we will begin and end on time for you. One of the other aspects that we have as a part of this is that we do this webinar every other year. Next year, we're going to be in beautiful Florence, Italy in October, a wonderful time of the year to be able to be in Florence for our in-person meeting. I think with that, what we'll do is to continue to move on with the sessions. You can see that they're organized in a way to be able to cover each of the key topics in shoulder arthroplasty from primary to revision. One of the real exciting areas, of course, is new technology in shoulder arthroplasty, thinking about this in 2023 and beyond. And with that, we're going to go ahead and start this session. Our moderators of this are going to be Dr. Verbote and Dr. Palladini. The way this is going to work, the lectures are pre-recorded, and then what we'll do is to have some live discussion. Again, this will help us engage with our faculty members, but also to be able to keep this program on time for you, again, valuing your time. So with that, Roberta, I think what we'll do, please, is we'll go ahead and start the first lecture by Dr. Barco, and then we'll turn that over to our moderators after each of the lectures are done.
Raul, are you ready? We cannot listen to you, Raul.
Ciao Paolo, but Raul can send the video, but is in the country. No, Raul.
Yes, I'm here, but
thank you, Raul.
Pucho, but I'm having problems with loading the presentation in the computer. I don't know what's going on here. So could you please, while I get the other one, so hello to everybody and thanks for the invitation. So I think it's better if they load the presentation, because somehow I'm not opening this presentation in my computer. I don't know what's the problem.
Yeah, so we'll go, Roberta, with the first pre-recorded lecture that you have available, and then we'll dive into discussion, please.
Perfect. Thank you so much.
Thank you, Raul, for being here.
Carica Raul e manda un link a Giovanni Di Giacomo perché
So it seems like there's no sound. So I will talk over this thing. Okay. So this is I would just thanking John and Pucho for the invitation. We are using nowadays 3D navigation, but we are missing of how doing our pre-planning and how taking this to the OR. So navigation is what gives us our best planning, our best tool to take our planning to the OR. Somehow this stopped. Did you stop the video? Okay. And so, well, we have nowadays very advanced 3D imaging, and this gives us, it improves our surgical planning. This is going very slow. Okay. We use now also machine learning tools to predict the outcome of the patients regarding motion and complications. It's very difficult to do the intraoperative evaluation of the neutral axis. This has been shown by Joey Iannotti, and we're not better than them. And so navigation really helps to get or find this neutral axis to place our implants. Oh, this is so strange. So the alternatives nowadays is the use of PSI navigation or augmented mixed reality. We really need to have like a aiming tool to improve our position and decrease variability. So there is a tendency, the market, we've seen this in the recent congresses, towards the use of augmented mixed reality. But this is Paolo and myself using these tools. Of course, these lenses, they are not really the ones we use nowadays, but they can be cumbersome. And I think we'll see this more and more in the market. You still have to do some intraoperative registration. So it's not like put on your lenses and then you're ready to go. You still have to do the registration intraoperatively so you can match the CT scan of the patient to what you're actually seeing in the OR. So this is one of the mixed reality tools. The classic, it's PSI. It has the problem of waiting and delivery time, and you will get a fabricated aiming tool and a glenoid model, and you have to match this positioning intraoperatively, and it just gives you the ability to place the neutral axis. So it does have the lack of verification tool. The pin placement can be problematic, some rigid shoulders, and you are able to bend that pin in some with some systems. So it's not perfect. So that's why we are using navigation. I'm sorry because this is going a little bit slower than anticipated. So what is intraoperative navigation? It is the use of a computer-assisted orientation in 3 axes on real time, and those 3 axes is version, inclination, and depth. You need triangulation of the system with an optical trackers that register between the iPad as you wish, and then a coracoid tracker that needs to be placed on the coracoid, obviously, and your tool that can be your reamer, your pilot axis pin, or your screws. So the thing I like about this system is that it lets you feel like a surgeon. Obviously, you do have to do your intraoperative registration. It takes 10 minutes at the beginning, the first 6 to 10 cases, but then it goes away. And this is the way you use it. You're using freehand, and then you're watching on the screen your depth, your version, and your inclination on real time. And so you can ream, you can do your 3D reaming until your desired length. Obviously, you can do the same for the post preparation, and you can do also the same for the registration of your final placement of your implant. Regarding rotation, this is very important with this system because it's not a circular metaglene. It's and you see there the images, and obviously there for screw placement, it allows us to increase our precision. This has been shown on this study to be almost perfect within 2 degrees of and we have shown clinically that there is decreased variability in implant positioning. We use less screws, but longer screws. We have been shown, this is data on files, hasn't been published yet, better outcomes with anatomical total shoulder and especially in reverse shoulder total arthroplasty. So use 3D planning, use the intraoperative navigation because it will improve your surgical precision. And now it has been shown to be a proven technology with evidence-based data to support it. Thank you so much. Sorry for the technical problems.
Giuseppe, John, do we do discussion now or at the end of this?
No, at the end. Paolo,
okay.
Introduce the next one.
Okay.
All right. Thank you, Raul. You're a real surgeon. You solved the problems as they were there. Thank you very much. We will go to the next speaker, Professor Pascal Boileau from Nice, and he will speak about patient-specific 3D planning for shoulder arthroplasty is the future. Can we load up the presentation or give the words to Pascal?
We cannot listen to you, Pascal.
Yeah, sorry. Do you start my pre-recorded talk, or should I do it from my?
What do you prefer, Pascal?
Okay, let's try from my computer. Can you see my?
Perfectly.
Yes.
Okay, so sorry. Let's start. So let's talk about shoulder replacement, and I would like to show you why I do preoperative planning for all my cases. This is my disclosure with intellectual property for this 3D planning with blueprint, Tornier, Wright, and Stryker. And this is what the software does. It allows you to do the 3D planning and to do the strategy, the tactic, and of course, to improve the technique. Why? Because you get automatic segmentation with 3D reconstruction, 3D measurements, and then you can do a virtual implantation of your prosthesis. You can measure the dynamic range of motion before the surgery, and you can plan to do patient-specific guide, prosthesis, or bone graft. The 3D software planning allows you to get these 3 levels of competence because it allows you to choose the right prosthesis, either the anatomic or the reverse, to do the virtual implantation, and you can do error on the software, but not on the patient, and to improve your technique by choosing the optimal size, position, orientation of the prosthesis, and to get the optimal range of motion. So let's do a case. You put your CD in the software, and then you can, this is real-time planning. You get immediately the 3D measurement of the retroversion, 36 degrees in this case, and 26 degrees of inclination. This is a B2 glenoid with a severe superior erosion of the glenoid. And what is important is that the software tells you that there is 92% of posterior subluxation of the proximal humerus. So this is a pure contraindication to do an anatomic prosthesis because you know that there will be recurrence of this posterior subluxation, and you know that you're going to have a very fast glenoid loosening. So this is why in this case, we prefer to switch for the reverse. So this is an example here where you have 3 different configurations. You see the reverse kick upward, neutral, or BioRSA with lateralization and correction of the inclination. And not surprisingly, you can see here that the BioRSA gives you the best range of motion. Look at that. Abduction from 0 to 32 degrees. Abduction from 78 to 87 degrees. Extension, 120 degrees. Flexion, 130 degrees. And rotation, 85 degrees for internal and 54 for external. So this is really the best range of motion. And this is summarized here. This is what you gain when you do this kind of planning and of surgery. So these are my take-home messages. The 3D software planning allows you to have 3 levels of competence and not to be only a simple soldier, which is a good technician, but being a good technician is not enough. I mean, what is important is to do the strategy, to choose the right prosthesis for the right patient, to do the tactic, to implant the prosthesis before going in the OR. And this is what the software allows you to do. Also, the software allows you to do virtual implantation of the prosthesis and to get some patient-specific guides, which means surgery without or with less error. And it's very interesting because this virtual implantation allows you to improve the positioning, improve the patient safety, the durability of the prosthesis, to save time in the OR, to have a team approach, to have a less expensive surgery because you have less storage in the hospital, and to have a scientific surgical approach and to do teaching. This is very important. All my fellows are planning the prosthesis before going in the OR. There is, of course, much more to come with the digitized shoulder. We'll have automated planning soon with artificial intelligence. We will have mixed reality with the HoloLens glasses, with the patient-specific guide, and the robotic with automated implantation. This is coming soon. But I want to show you that if you do the planning, and I did the planning for this lady in the 2 shoulders, I did the same surgery the same day on both shoulders. She has an anatomic on one side, a reverse on the other side. She's 6 months after the surgery. She has good internal range of motion. She cannot make the difference between the anatomic and the reverse prosthesis. So for me, the planning has completely changed the results for my patient. And this is the most important because I have improved the care of my patient. I have decreased the risk of complication and revision. I have saved time, and I have a team approach with reduced stress for the team. I have reduced the cost for the hospital, and for the manufacturer, it drives the business while reducing the inventory, of course. Thank you for your attention.
Thanks, Pascal. As usual, you are a very interesting presentation, very interesting concept that we can develop after. Now it's my turn to introduce Olivier Verbocht with his presentation. Thank you, Olivier.
All right. Thank you very much. So let me state why I think robotics is the way to go in the future. So we know that shoulder replacement is a successful procedure with a 10-year survival of 92% for anatomic and 93% for reverse arthroplasty. But nevertheless, about 10% of our shoulder arthroplasty patients remains dissatisfied with their result. And that's a little bit in between total knee arthroplasty with 20% and total hip arthroplasty below 5% after an implant. As we all get better doing our surgeries with newer techniques and better designs, we tend to tackle more and more difficult cases. First of all, young patients with difficult deformities and still high expectations, but also older patients with difficult deformities and higher demands than, I would say, 2 decades ago, where elderly people would just sit on the couch and not come to see the doctor. Today, we're using X-rays and CT scans or MRI to sort of plan our surgery, and then during the surgery, we use standard instrumentation to place the first central pin and use cannulated reamers to prepare and do the implantation of the glenoids. It has been shown quite extensively that this is not always reliable. It results quite a bit in outliers and errors up to 10 degrees. Also on the humeral part, there's the same challenge. Whether you use a freehand technique or cutting guides, it seems like we're not so precise as we would like to be. We already heard this in this session, of course, that 3D planning has changed our lives quite a bit. We're better prepared to go to the surgery, and we can even virtually plan humeral and glenoids, and then also range of motion and free impingement range of motion in the patient that we would think would be working best. Now, the question is, of course, how do you execute? And we already heard from the previous speakers that patient-specific instrumentation is there. It's reliable, and it's probably quite accurate. It's between 2 and 4 degrees, which is better than standard techniques. And augmented reality and mixed reality are the new kids on the block, and have been shown to be promising in terms of reducing errors. But still, we try to continue to implement technology to improve these surgeon control variables. And so we know from other specialties and other businesses that the robots are extremely precise, and we expect that this will be the same thing when we'll bring them into our surgeries. The first robotic surgery that has been done in robotic system in surgery has been done is 1985. The Puma, what was used to assist in stereotactic brain biopsies. The real cornerstone in robotic in surgery was the introduction of the Da Vinci system where they proved clearly some advantages over standard instrumentation, standard surgical techniques, and it was finally brought into their field as a broader adaptation. And for certain pathologies, it evolved to real standard of care, such as prostatectomy. For orthopedic surgery, we saw that the introduction of the RoboDoc was the first step in that direction, where the robot improved the femoral fit and position of the femoral stem. This has led to significant evolution of robotic-assisted joint arthroplasty over the last 2 decades. Specifically for arthroplasty in the knee, this has been a big game changer. 600% increase in robotic-assisted total knee arthroplasties over 5 years in the US. And what has driven this is that, first of all, 20% of conventional total knee arthroplasties were unsatisfied. Conventional instrumentation frequently was associated with malalignments, and the gap balancing and joint stability assessment remained very subjective and was depending on the experience of the surgeon. So many major companies now have robotic systems, and they're all a little bit different. There are imageless systems that require plotting of reference points to recreate 3D visualization. Some use burrs, others use guided manual saw. And there are also systems like the Zimmer Biomet and the Stryker robots that are image-based, which combine the use of preoperative CT and MRI and referencing to bony landmarks. And they have shown, for example, in arthroplasty of the knee, that it's been very, very accurate and reproducible. For shoulder arthroplasty, of course, there will be a lot of opportunities. It will bring the 3D planning at the next level. It will allow us as surgeons to actually do the 3D planning during the surgery, adapt and execute as we go on, and what we think is better for the patient in that same case. So it will be very patient-specific surgery. We'll use robots to more accurately do our bone resections, again, adapted to the patient's anatomy in the preoperative planning. We'll do that for humeral osteotomy and the glenoid reaming in terms of height, version, inclination, and depth of the reaming. There will be boundary control to assist the surgeon and restrain the surgeon during the humeral osteotomy and glenoid reaming. And finally, also during the surgery, you'll be able to validate your cuts and your glenoid reaming, and if you want to correct it if needed, just like the knee arthroplasty guys have done that. And then finally, I think in the future, there will be motion tracking technology. You'll be able to check the intraoperative range of motion, adapt, check the soft tissue tension, let the robot help you and determine how to get the optimal joint stability. Of course, there will be challenges with this new technology, and definitely cost is one of these. Not only the acquisition of the robot, but also the procedural costs will increase, and there will still be a learning curve. And in the end, the surgeon's intuition remains cardinal when using this type of technology. Lastly, we'll have to show that it's better than the standard. And just like in total knee arthroplasty, if you want to prove that it will lower the revision rates, you'll have to see for long-term results and randomized controlled trials. As for now, superiority in accuracy and precision was not directly translated to improvements in clinical outcomes yet in total knee arthroplasty. But in the end, I think the computer or the robots will close this circle of digitalization in shoulder arthroplasty, and will be able to match all these data during the surgery, but also preoperatively and postoperatively, all together to one story, and we'll hopefully have more guidelines and decision trees to make the right decisions when we're planning and doing shoulder arthroplasty. So thank you, and hopefully we'll see you next year in Antwerp.
Thank you, Olivier. Now is the time for Bruno Gobado to show us the metaverse who can influence our knowledge. Please, Bruno.
Thank you very much. Okay, my name is Bruno. I'm speaking from Brazil. Thank you, John. Thank you, Porcellini, for this opportunity. We are going to, this is my disclosure, and the objectives for this presentation is to show how can we use augmented and virtual reality for teaching, training, discussing, how do I use in surgery in the future? And remember, most of these techniques and apps that we are using are free to use, just like this webinar. So just to start, it's interesting to understand the difference between VR and AR, or virtual reality and augmented reality. Virtual reality is when we are totally immersed in a glass and we have only the digital world. So this is very interesting for practicing. This is an example of Precision OS. There's a software that to practice shoulder arthroplasty. And we are now merging to Orthoverse, which is the merging from VR, AR, and now we are calling that extended reality. Well, this is just a name. But this example, how can we use AR, augmented reality, for a planning? This is a planning of a reverse total shoulder arthroplasty with a graph. The graph is in red. So we can have the planning in our hands with a free software. We can see, for example, the anatomy. This is a clavicle fracture. So this is very simple. You can export this planning from your computer to a simple system of augmented reality. You can use the same piece of paper and fold into a cube. And then we have a system like that you can use in 3D space, and you can have your planning. This is an example of how we can use the planning. Now we can see this is a planning of implant cast implant. We can check that there is a retroversion. So this we can use to reproduce in surgery. Here, example, not of arthroplasty, but how can we have our planning in 3D in the OR? So we can check prior to the surgery, check everything is correct, if the position is correct, and we can double check with our planning in our screens. Now we are using extended reality. For that, we need special glasses. Today, we are using HoloLens, but we are expecting Apple to release in the next month a glass, so we can use. And we can use it also for planning. This is an example of a planning. So this is how we do. We always plan the central pin guide. So we're going to use that in the surgery to direct the implant. Then we plan the position of the implant to check if the position of the implant is in the correct position that we have already planned. And then if we want, we can develop our own patient-specific guide. This is one example of a patient-specific guide. So we have all the technologies in the same field of view, in the same software. This is our first case that we did in 2017. This was a very severe retroverted. We choose to do a bio-RSA with a very big graft. So as it was very inclinated and it was even difficult to use the PSI, we choose augmented reality to check if the position of the implant will be in the correct position, since it was a very difficult case for us. This is another example of how can we use mixed reality as a remote assist. This is the field of view from the surgeon in Switzerland, Mohitaha, and he's doing the surgery, and I'm watching the surgery in my computer. And then I placed my mouse in his screen, and that yellow arrow is placed exactly in the humerus where he should do the osteotomy. So we are doing remote assist for surgery, or we can do, actually we are not doing, but it's a technology that we can use. This is not for arthroplasty, but we can have as many screens as we want. This is an example of a shoulder arthroscopy that we are using 2 cameras, and we can put that screens in any position, even to do this, to place the screens as the reference anatomy for the patient. And we can have 1, 2, 3, 4 screens, no matter what. For discussion, for example, for this discussion that we are having here, we could have this discussion in augmented reality. This is my office, and we are planning with Mohitaha in Switzerland, reverse total shoulder arthroplasty. We are discussing what we are going to do, so we can do that also virtually in augmented reality. We can have more people. Now we have 4 surgeons around the world. I'm grabbing the 3D model. Now Mo is grabbing the 3D model. We can use pictures. We can point at pictures. We can show the CT scan. We can show, for example, now John is pointing for what he thinks it's a problem. So that can be also do in AR. We can use also VR, now virtual reality. This is a workshop that we have developed. It's a free software. You can develop yourself. So it's a workshop that we developed to teach how to plan and to teach exactly the steps for the procedure. And we can also do the planning in VR. I'm just ending. So this is also a free software that we are using now VR, and we can import the models and we can do all the planning. Now we are planning how to do the osteotomy. So this is the plan that we're going to use to cut, and that can be done in VR, and then we can export for your computer or for a AI model. And we can also prototype. This example of a VR session that I use the robot Mako, and we are very interested in when the robot will be available for us. So I developed a robot, and now I'm testing, well, how the robot will enter, how I will be next to the robot. What will be the angle for the robot to do the surgery? So here we can prototype in VR. This was done in a free software. So I'm prototyping where the auxiliaries will be, where the robot arm will be. So we can also prototype robotic surgery to check if the position is okay using VR. So that's what I have to show to you. Thank you very much for the invitation.
Okay.
Thanks.
It's time for discussion, and there is a question from Andrea Giorgini asking if we believe that this kind of system can improve the survivorship of the prosthesis. Or Pascal already answered us, and the question is to Olivier and to Bruno.
Yeah, so like I said, we need longer term follow-up with this new technology. There is not a long-term follow-up yet, so survivorship, we don't know. But we expect that if you're more accurate in placement of your components and choosing better indications in terms of anatomic versus reverse, the result and the survivorship should improve.
And my answer is that when I practice the surgery in planning, in VR, in AR, I'm doing the surgery for 1, 2, 3 times. So probably in the 4th time, where will be the real surgery, the surgery could have a better outcome and a better reliability and accuracy. That's my opinion.
Giuseppe?
For me, it's very interesting to increase the experience in technology. First of all, the problem of augmented reality. I have a mask, but sometimes it's very difficult to overlap the HoloLens to the anatomy. So you don't check the key wire if there is in the right position. My experience, our experience with Luigi is the same in Europe or around the world or not. So it's a step, but is not the final instrument to be a good accuracy. In my experience, augmented reality.
I believe it's better to have a good preoperative planning than a bad virtual intraoperative reality. I think, frankly, preoperative planning is everything.
Yeah.
I mean, if you decide to do a battle, you need to know your enemy, and you need to know it before you go on the battlefield, not during the battlefield. So for me, preoperative planning is the most important. Of course, if we can in the future have real nice intraoperative tools for this kind of virtual reality or augmented reality, and for this navigation, it's nice. But when I see some of these videos where people navigate, it's something surprising to me, because they are navigating in a wrong direction, if I can say, because you cannot take the decision during the surgery. It's before the surgery, before going in the OR, which to me is important.
Yes, of course, Pascal. But when you introduce, for example, the key wire in the right manner, are you sure the inclination is a version is right? Because for a very expert surgeon to identify the point of insertion is easy. But sometimes 10 degrees in antiversion or 10 degrees to arrive to RSA angle. You are incredible study about that. Are you sure during operating time to be online?
If you are not sure, I mean, you should order a guide, a patient-specific guide. And then the key wire will be perfectly placed, you know. And it can be a patient-specific guide done before by the company, or you can use a tool that allows you intraoperatively to adjust inclination and retroversion. But you're right that what is important is to realize that if we really want to have good results, I think, in my experience with the reverse, we should go as low as possible on the glenoid. And sometimes I see that surgeons still stay in the middle of the glenoid for reverse prosthesis. So it's another concept. It works, but I don't think it provides the optimal range of motion.
Okay.
Paolo, posso fare una domanda? Sì. My question is, how in the future navigation, 3D planning, robotics, metaverse can help in understanding not only the glenohumeral joint, but all the shoulder girdle. I mean, the scapulothoracic motion, considering that is individual, the scapulothoracic motion, and this influence the torque, the moment arm, the length of the muscles, the velocity of a contraction of the muscles, at the end, the force of the muscles. How can help in the future this technology all the shoulder, not only the glenohumeral joint?
Paolo?
Io ho finito tutta la voce, non riesco più a parlare.
Bruno Gobbato, how do you think about Bruno, the position of scapula? Because of course, Bruno, Giovanni says is important, but the scapula and other joint, do you consider in the future, Bruno?
We have to have sensors for that question. So we have to have intraoperative sensors. We may have post-operative sensors, I think, to have data to answer that. We don't have biomechanical data from our arthroplasty. We only have anatomical data from our arthroplasty. So I think when we move to sensors, and I think we are a little bit behind, we will be able to answer that question.
Olivier, ciao.
Yes.
Olivier, accuracy of, you have a lot of experience about PSI, but in the knee, for example, PSI showed not a lot accuracy in the position of prosthesis. Do you think in the shoulder joint is completely another idea, or PSI is just a step for navigation or robotic?
Yeah, I think for shoulder, PSI has been shown that it is very efficient and it is very accurate for the glenoid. But I also I used to do navigation a long time ago, earlier systems, older systems. What I liked about it was that the dynamic aspect of it during the surgery, and that's what I miss now with the PSI guides. So I hope in the future we'll have something that is as accurate or more accurate than PSI, but that gives you some dynamic feedback during the surgery.
Well, Olivier, that already exists. That's navigation. So
that's true. This is
I think the problem is it's quite a problem in regarding the Giacomo's question. Is that, of course, we know that the scapula position on the thorax may affect the position of your implants. We know it can affect your the position of the version of the implant if you want to achieve internal rotation and good external rotation, because the position of the scapula is changing on the thorax. And also, if the patient is very kyphotic, the scapula is protracted and it will not elevate as in a normal non-kyphotic patient. Hopefully, we can do this also with clinical assessment. I think we are not ready yet to do that step, in my opinion, and to include all those parameters in a patient in planification guide. I think we are still trying to guess the best solutions for the humerus and the joint architecture. So I think we're not ready for that, but we have clinical assessment. We are surgeons. We see our patients. We have to look at this in our clinical evaluation, check if the patient has good motion.
Raul, 2 questions from audience, Cristobal Calvo and Victor Naula about complication. Complication during the operation in navigation and the problem of deltoid. Do you change indication? How many shoulder implant do you stop navigation and you go without navigation?
Okay, so I've been using navigation since 2017, and we have used it consecutively in all our cases. This is for learning experience, and I think probably you don't need it for every case, but we've done it like so. And personally, I just remember one case, which extreme medial erosion. The coracoid was paper thin, and when placing the coracoid tracker, the coracoid broke. And then, of course, you are burnt for the case. You cannot navigate. But I think Pascal's point is great, is that you have done the surgery with your planning. And we're still surgeons. We can look at your paleoglenoid, and after I found that, I kind of looked at my neutral axis, and we can get some orientation. So still, even if you cannot navigate, your planning helps you a lot, and it has been shown. This has been shown over time. So really, not many more complications with using navigation. It takes a little bit more time at the beginning, but my approach is the same.
Coming back to your experience with navigation, do you think that we can change our idea in case of a very difficult situation about the soft tissues? If you have a so retracted muscles, or if you have a soleax shoulder, soleax muscles, do you think that you can change your preoperative planning if you find too strict shoulder or too lax shoulder, or different position as you told for kyphotic patients?
Yes. So for now, the system I use has only glenoid navigation. It has humerus navigation it's on beta testing. And then you have the joint architecture, the whole joint architecture on beta testing. And the system has a sensor to assess for soft tissue, like a tension on the polyethylene, pressure on the polyethylene. But now at this point, we are just gathering that data. So we just don't know what the data is, this means, and we will correlate this in the future with the clinical outcome. I think this is very difficult to assess, but obviously you can do 2 plans, you can do 3 plans, and you can save them all, and you can change during the procedure. So you're able to do multiple plans.
Okay.
Pascal.
Yes.
You decide in preoperative planning the implant. But during the surgery, you have different osteosclerotic, glenoid, or different quality of bone. Do you change sometime your idea, or what do you decide in preoperative exactly reproducing 100%?
Of course, you should adapt to the patient's anatomy and pathology, and it may happen that you have to modify a little your plan, but it's not because of the bone problem, in my experience. It's because of the soft tissue problem. For instance, I systematically do a bioRSA, which means I systematically do glenoid lateralization. Sometimes I plan, what I like is to have a graft which is standardized, which is 12 millimeters superiorly, 6 millimeters inferiorly to correct the RSA angle and to lateralize. And sometimes in small patients, maybe the graft is a little too big, you have to adapt. And what I do then, I compress more the graft to have a little less lateralization. But basically, I don't diverge from my planning because it's really reproducible. Of course, it's different if you're treating a fracture sequela. This is another story. Okay, then you cannot really do what you want in this case because there is a circular contraction of the soft tissues. There is bone deformities, and it's much more difficult to manage. But for the standard cavity arthritis or massive cavity or osteoarthritis, I mean, the planning is good in 99% of the cases. One thing I would like to add before maybe we finish is that most of the surgeons today have understood that glenoid lateralization is important, either with bone or with metal. But we must remember that Grammont had two principles which made the success of his prosthesis. One was medialization and one was distalization. And we have abandoned one of the principles of Grammont, which is medialization by doing glenoid lateralization. The key point today for me is to understand really the optimal distalization, because we cannot abandon the second principle of Grammont, which is distalization, because this is what gives the deltoid the strength to overcome the weak cuff muscles. Okay, so for me today, it's more a problem of soft tissue measurement, and we are not able to do that to have the optimal distalization to really overcome the weak cuff muscles. And this is why, as I said, I'm surprised when I see that patients that put their glenosphere or their base plate in the center of the glenoid, because it means they tend to abandon the second principle of Grammont, which is distalization. And this is, in my opinion, something that we should not do if we want to have optimal range of motion. Good.
Pascal, wonderful comments. And again, you can see there's no lack of controversy and different perspectives. I'd like to thank all their speakers as well as the discussion. I think with that, we're going to transition over to our next group of lectures, which is going to be moderated by Dr. Weiser and Dr. Randelli. And with that, I will turn the next session over to both of them to introduce the speakers and then the recordings.
Thanks, John. Thanks a lot, everybody. Very nice to be here with you. And so we will start the second session. The title is Techniques in Anatomic Shoulder Arthroplasty, the Key Steps for Success. And I would like to introduce the first speaker, who is Dr. Paolo Palladini. He will show us a presentation about the key steps in glenoid exposure. Please, Paolo, if you have enough voice, keep going.
Thank you, Pietro. I think
maybe we can see if we have the recording. Roberta, do you have his recording?
Thank you, John.
Maybe if we have the recording is better.
The video of Professor Palladini.
You don't have? Yes.
Okay.
Dear John, dear Giuseppe, thank you for this opportunity to share with you my knowledge about the key steps on glenoid exposure. As you can see, there is a lot of papers and a lot of videos where we can see which are the key steps to expose correctly the glenoid to do a correct implant of the prosthesis. Of course, it's so difficult to have a correct exposure of this kind of glenohumeral arthritis, this kind of joint, respect to this one, where is so lax, where is the disease so simple to achieve a good exposure of the glenoid, even if we can have some difficult problem in a second phase, in a second step of this implanting, with this challenging implanting. But Luis Bijlani suggested us that with some retroversion of the glenoid, you can have more difficulties to expose correctly the glenoid, and that you have to do a very good exposure to do this challenging implant. The first step is the the mobilization of the deltoid. The deltoid is quite, in some cases, so strict correlation with the humerus. So you need to detach the deltoid from the humerus to have a correct mobilization of the humeral diaphysis. We start, of course, from the superior side, from the superior edge of the cephalic vein, and we follow the vein so we can detach the deltoid. And after this, we reach the humeral head after the touching of the subscapularis. It's really important to detach the capsule from the medial side of the humerus. You know that the capsule is like an hammock, so you need to detach the humerus from the capsule from the humeral side to permit even the detachment of the capsule from the medial side, from the glenoid side. In some cases, we can even accept to have some comminution of the lesser tuberosity in case of a very tightened posterior wear of the glenoid. In this case, we can even accept to have a comminution of the lesser tuberosity. But we start from the positioning of the patient to have a correct exposure of the glenoid, because if you put the patient in the right position with nothing on the posterior side of the capsule and with the possibility to achieve a good abduction and external rotation, in this case, as you can see from the inferior part of the slide, it's quite simple to have a correct exposure. The detaching of the subscapularis is quite important because you have to reach the inferior part where you can have the three sisters that can advise you that there is the axillary nerve just beneath them. The reduction of the humeral head, removing the osteophytes first, and even reducing the dimension of the humeral head, it's quite important because the humeral head is going to increase its dimension during the last phases of the arthritis too, because we have a missing of the cartilage, so it's important to remove even all the osteophyte, inferior osteophyte. Clever instrumentation can give us the opportunity to have a more simple introduction of these devices, of this instrumentation inside the joint, as in this case you can see where the circle of the glenoid burr is just for 2/3 to let us facilitate the introduction of this inside the joint. And Gerald Williams, some years ago, gave us the 10 top tips for glenoid exposure in shoulder arthroplasty. As you can see, we start from the retractors, removing the humeral osteophyte, doing an accurate humeral cut, and of course, to have the possibility to move the humerus all around and to have, in this case, so you can move and have the correct exposure of the glenoid. Of course, the proper retractor replacement is important. As you can see from the superior side, you just need 3 or 4 retractors. The first one on the glenoid neck anteriorly, the second one on the posterior side, and the one smaller in the upper side and the inferior side. And even using a laminar spreader can be useful in select situations when you have a too tightened posterior capsule. The removal, we already spoke about the removal of the capsule from the humeral side, and of course, even from the glenoid side. As you can see in this case, we identified the space between the superior glenohumeral ligament and the medial glenohumeral ligament. You can insert a retractor there. In this case, you isolated completely the capsule from the subscap, and it's quite simple to follow this plan that we have until the inferior part, removing all the capsule in one shot, as you can see in this case. The last but most important part is the releasing of the posterior inferior capsule from the glenoid. If you are able to release all the complete posterior inferior capsule from the glenoid, you can have the right exposure of the glenoid. In conclusion, I would like to conclude with this slide taken from Carla Basamigna presentation, where he suggests that if you are not able to do a correct exposure of the posterior inferior part of the glenoid, maybe it's better to continue with the hemi arthroplasty. Thank you still for this opportunity, and let's have the discussion.
Paolo, thanks a lot. This is Carl. Hi, nice to meet you all. I need to apologize. I have no video stream. I don't know why I cannot turn on my video, but I was with you all the time. I think we'll discuss all the talks at the end, and I would like to ask Dr. Campi to talk about the subscapularis sparing anatomic shoulder arthroplasty.
Roberta, pre-registration, please.
Hi, everybody. Many thanks to John and Giuseppe for this kind invitation. I apologize and I'm very sorry that I cannot participate directly in this meeting. We talk today about the subscapularis sparing and anatomic shoulder arthroplasty, an infrequent surgical technique, and I'll go a little fast given the time available. The subscapularis is essential for implant stability and function after anatomic total shoulder arthroplasty. The subscapularis provide the soft tissue balancing and support the various functional activities of the shoulder joint. Subscapularis insufficiency after a total shoulder arthroplasty, in particular the anatomic total shoulder arthroplasty, has been associated with the implant instability and poor clinical and functional outcomes, often necessitating revision surgery. Reported subscapularis rupture rates following a tendon-to-tendon repair have varied widely. Up to 67% of patients have been found to have abnormal examination findings related to the subscapularis after total shoulder arthroplasty. And the failure of the subscapularis tendon required revision surgery has been shown to be 5.8%. Given the relatively high rate of subscapularis complication in traditional shoulder arthroplasty, surgeons have developed alternative techniques to perform the total shoulder while maintaining the integrity of the subscapularis, minimize the potential for failure arising from the subscapularis insufficiency, and allow early aggressive rehabilitation. First authors to report a series of patients who were treated with the total shoulder arthroplasty through a subscapularis sparing approach was Laurent Lafosse in 2009. 22 consecutive patients were treated with the primary total shoulder arthroplasty using the superior approach that doesn't violate any of the tendon of the rotator cuff and is performed entirely through the rotator interval as originally described by Neeraj in 1982. Indication and contraindication to this procedure are the same as those for an anatomic total shoulder arthroplasty using the dectopectoral approach and may include substantial glenoid wear or rotator cuff pathology. The patient must have at least a neutral external rotation in order to allow adequate visualization of the rotator interval. For the positioning as a classical beach chair position is used and place the torso lateral enough on the operative side so the medial border of the scapula is on the edge of the bed, or remove the posterior side part of the surgical bed. This allows full extension of the arm during the surgery and avoids neurological injury due to excessive traction. The anterosuperior straight incision is made along the Langer line beneath the skin, carry the dissection medially to the level of the acromioclavicular joint and anteroinferiorly so that the raphe between the anterior and middle deltoid is exposed. Take care to avoid splitting of the deltoid beyond this level, 4 centimeters more or less, to avoid iatrogenic injury to the axillary nerve. A stay suture may be placed at the inferior extent of the split to help avoid propagation and potential injury to the axillary nerve. Release of the subdeltoid adhesions is an important step to mobilize the tissue planes and thereby facilitate the deeper exposure, particularly in patients with limited preoperative motion. Externally rotate the shoulder to bring the rotator interval inside the flap of internal tissue from 5 millimeters posterior to the long head of the biceps tendon, exiting the shoulder joint and piercing the coracohumeral ligament. After performing the release of the long head of the biceps inside the interval tissue, straight back to the glenoid from the upper edge of the subscapularis, creating a triangular piece of tissue referred to a trapdoor attached to the supraspinatus. Tuck the trapdoor under the supraspinatus and use a direct retractor to define the interface between the rotator cuff tendon and articular cartilage, and expose the hinge point where the supraspinatus attaches at the junction of the humeral articular surface and the greater tuberosity footprint. This marks the line for the saw blade entrance for the humeral head osteotomy after intramedullary guide is placed. The typical native retrogression is readily apparent at the surgeon is directly visualizing the relationship between the humeral head and the glenoid. At this point, take care to retract the supraspinatus out of the cutting plane. The use of the safety saw is critical to avoid injury to the anterior and posterior cuff from excessive exertion of the saw blade. Over-aggressive advancement of the saw blade medially may place medial structures such as the axillary nerve and artery at risk for injury. In the largest shoulders of those with excessive deformity, it may be necessary to cut the head into two pieces to facilitate extraction. In most cases, the medial goat's beard osteophytes are removed with the humeral head without an excessive varus cut. However, in some cases, a curette or medial chamfer cut with the saw may be required to remove them. One self-retaining retractor is placed to retract the skin only, while the other deep retractor is used to retract the subscapularis and trapdoor tissue is flipped deep to the supraspinatus. Release the capsule in the periosteal plane around the glenoid helps to avoid the axillary nerve. To be able to do a better capsule release and better view and medial osteophytes, other techniques have been developed. They have shown encouraging results with no complication regarding the subscapularis. However, the published results were only on case of hemiarthroplasty. In subscapularis sparing as an anterior technique, a Oman retractor is placed through the window and retracted inferiorly and medially. Often, it is progressively walked around the inferior neck and the capsule and osteophytes are released and progressive external rotation and flexion are accomplished. The rest of the procedure is done through the rotator interval like the technique described by Lafosse. Estimate the humeral head size measuring the medial to lateral distance across the previously made humeral head cut, and unfortunately, not all humeral trial components and implants can be used in this step, and especially not the longer difficile fitting stems. Normal anterior translation is less than posterior, and this is appreciated with this technique. Close the trapdoor and rotate the shoulder externally, and take care to not overconstrain the interval by excising the interval tissue and suturing the subscapularis to the supraspinatus. Retouch the deltoid to the acromion using transosseous permanent number 2 sutures. The initial outcomes published in the original paper by Lafosse were periotherapy to postoperative improvement in the constant score, VAS, simple shoulder test, active forward flexion, and strength. By revisiting the Lafosse technique, some authors expect improved results by providing a better humeral head visualization and consequent better osteotomy, less residual inferior humeral osteophytes, and enhanced humeral head sizing. In conclusion, at a short-term follow-up, the outcome of total shoulder arthroplasty using the subscapularis sparing surgical approach was similar to that after total shoulder arthroplasty using the standard surgical approach. Thank you very much for the invitation and for your attention. Thank you. Bye.
Thanks for this lecture of Fabrizio. I'm sorry he's not here with us because it's interesting to discuss this paper at the end of the session. So now the next speaker will be Dr. Babulkar from Pune, who will speak about stemless anatomic shoulder arthroplasty. Thank you.
Roberta, we can go ahead and play the video if it's available.
Okay, Professor.
It should be available. If it's not, I'm happy to present it. Yeah.
Hi, this is Ashish Babulkar from this side, from Pune, India. No doubt, it is a bone-preserving operation and minimizes soft tissue dissections, allowing for a better preservation of biology. The anatomic reconstruction with the stemless is far more accurate, and hence the results seem to be better. But the undeniable fact is that the version restoration is near perfect with the stemless, giving us a better result, is my impression. These are easy to revise, and the stem-related complications are almost absent. For me, since I deal with sometimes small female patients who have a much smaller head of humerus, it is important for me to understand the stem distance. And that's why if one doesn't have a pre-op planning software, one needs to do this on the pre-op X-ray and pre-op CT scans. On the approach, I'm largely sold to the deltopectoral approach because that allows me to handle the subscap and remove osteophytes much easier. My choice of the deltoid split is few and far in between on some cases, and the subscap sparing I reserve for those easy patients who have a good range of movement and very little osteophytes, where I'm not required to do bigger releases. So the key thing is placement of the guide wire, and I think once the guide wire is gone in, the rest of the process is pretty much automatic, smooth, and fast, and that is what I like about the stemless arthroplasty. But the sizing is very critical. I have a little bit of liberty of undersizing, oversizing marginally in a stem prosthesis, but in a stemless, it has to be accurate to the micromillimeter. And so on resection, I would measure the head, check which are the sizes. There are some prostheses which have 5 different trials and heads, whereas most of them will offer just 3, which makes a limited choice to accurately match the ellipsoid head of the humerus. The resection is pretty much standard because of the smaller incisions, especially in the subscap sparing approach. I end up doing a freehand resection like most of you must be doing because the placement of jig can be tedious. I am very easy on using the Shyam intraoperatively so that I know that my positioning is accurate and I'm trying to restore the native anatomy as accurately as possible. So in both the orthogonal planes, I would review and ensure that my final implant has gone in and sized perfectly well. And that is exactly why I often always have a hemiarthroplasty stemmed on the back table in case things don't pan out as planned, especially in those gray areas where there's AVM and deformity of the head. And I expect a lot of osteopenia. Sometimes the soft bone does not allow the stem prosthesis insertion. And I also use the live Shyam at the end to put it into all 360-degree movements to ensure that I have sized the prosthesis correctly in all and good range of movement. So this is one of our 4-year follow-ups and he's done fairly well. I think the stemmed and the stemless arthroplasties will allow us restoration of good function, but the stemless is unmatched if you're able to actually restore the 3D anatomy. The key thing in a shoulder joint is to restore the rotations, because if you get a good external rotation and internal rotation, then we can offer the patient all the 6 degrees of freedom accurately. Not only that, I have also noticed that in the patients that I have done a hemi without having a polyglenoid in place, I see that the glenoid vault has medialized progressively over 9 years. Since she's asymptomatic, I'm compelled to follow her through, but I have to watch this very closely, and that's why yearly follow-up is mandated. In conclusion, I have an inkling that the results could be prosthesis dependent, especially when the studies go into the long term. We might see a difference between the screw designs and the fin designs, but only time will tell that. One needs to watch the glenoid vault wear in the hemi that have been done without the glenoid poly. Otherwise, that is the main difference between the hemi versus rotoral. Revisions tend to be easy. The short-term results are above average. I am free to allow sports on these patients, especially swimming, table tennis, and golf. And that's a big advantage and plus in the more energetic population. The future, the availability of the ceramics and some of the other materials might help improve even the current results. But I think the stemless arthroplasty options has a bright future ahead in select group of patients. Thank you very much for your time. It's been a pleasure.
Thanks a lot.
Thanks a lot for this talk. We will discuss it later on. And I would like to ask Dr. Giovanni Merola talking about the all-poly glenoid component.
Yes.
And Roberto will continue to play the videos. That would be great. Thank you.
Okay, it's okay. Okay, let's go. Thank you. Thank you, John. Thank you, Giuseppe. Do you see my presentation?
Not yet. Roberto, do we have the video or not?
Do you see it?
No, because we see the...
I think you shared the wrong screen. We see...
Giovanni, vediamo il tuo Finder. Non vediamo la presentazione.
Ok.
Condividi la presentazione, non il Finder.
Ok. No, perché io... Aspetta un secondo perché ho fatto... Vabbè, condivido l'altra cosa, dai. Just 1 second, please.
Yes, we have only the slide of Dr. Merola, not just the pre-recorded video.
No, we have to see the slide, yes. But we tried it. Now I try to share the presentation again, okay? Okay, let's go. Let's start. You should see now.
Noi la vediamo, sì Giovanni, grazie.
But I tried to use the PowerPoint because
Go ahead, we see it. Go ahead, far ahead.
It's okay. Thank you for this invitation. Sorry for the technical problem. Our experience with the glenoid components began in the 1998. We at that time we used the 3 pegs all-poly glenoid component, and at that time we had a good results at mid-term result, 5 years, with all cemented polyglenoids. Then additional studies were performed to identify the glenoid at risk. So we used the CT scan to assess the fixation of the glenoid and to assess the cases of migration. My preferred approach in total shoulder arthroplasty is in primary osteoarthritis, in patients with the intact rotator cuff, and preferable under 65 years old. But of course, we have some challenging issues. First of all, the problem of the rotator cuff deficiency, and also the glenoid deformity. Our mind changed in the assessing of the glenoid deformity. We started with the assessing in the biplanar way, and now we know that the deformity is more complex, it's multiplanar. And so, as Pascal demonstrated in the previous presentation, the preoperative planning for me is strongly advised. The potential objectives of glenoid replacement should be to fix the glenoid, minimizing the rimming and preserving the bone stock. This is the great problem, because we should prevent the medialization of the joint line. So you can see in this image the preparation of the glenoid with a good compromise between the rimming, the need of the correction of the version, and minimize the medialization of the joint line. So you should test with the trial the position of the components and try to obtain at least 80% of sitting. It's not easy to obtain. Another problem that I would share with you is the key weak point of the glenoid. We know that the anterior-inferior edge of the glenoids is the weak point, because in that position, when you fix and you impact the glenoid, is at risk of producing microfracture. This type of microfracture, especially with the pegged glenoids, can foster in the mid and long term the loosening of the glenoid. So when you fix the glenoid, be sure to place the glenoid in the scapular plane during infection. Additional problem, when the glenoid is severely eroded, especially in B2 and B3 glenoid, it's very hard to place a standard glenoid without removing too much bone. So the use of augmented polyglenoid may be an option. For me, this type of glenoid are an option in patients with posterior central and posterior defect. When there is an important upper part erosion of the glenoid, for me, this type of glenoid are more at risk. Much more, 35-degree augmented glenoid are more at risk of losing, because this type of glenoid, the seating is good, but the angle is too much. So in my experience, we should be very careful with this type of glenoid. Our trend now is to use not partially cemented glenoid with a bone ingrowth central peg. This type of technique is similar to a fully cemented glenoid, except for the central peg that should be fixed without cement. Some years ago, Rick Madsen asked me to share with him my results on the use of this type of glenoids. And the conclusion of this study, including 11 centers, was that it's not clear if the use of augmented glenoid are better than that standard glenoid. This is another study performed by my group in 2016. At that time, I used the CT scan to assess the filling of the central peg by bone. As you can see on the left side, you have a CT scan in coronal scan that compare the filling at 2 months with the 29 months. And on the right side, a case of a glenoid where you can see osteolysis of the central peg. Anyway, despite this result of this glenoid, we had good clinical outcome. So at 2 years, we can consider this type of glenoid a good option. Now I am studying the long-term result to see any differences. These graphs demonstrate the correlation between the Young score for the radiolucent lines and the Arnold score used to assess the bone growth of the central peg. You can see a good correlation between the filling of the central peg and the radiolucent lines. Of course, we can have problem, as in this case. This is a loose glenoid, but as an expert surgeon know, the loosening of the polyglenoids is very well tolerated compared to the metal back. And also the revision of this type of glenoid is easy. This case was converted in reverse without removing the stem in half an hour time of operation. Thank you.
Thanks a lot, Giovanni. And now the metal back convertible glenoid component, and Alex Castagna will present it. Alex?
We're going to use Dr. Castagna's video. If we can please put that up, Roberta, that would be wonderful. Yeah. And then we'll have Dr. Castagna speak.
Okay. Dr. Merolla, stop is
yes.
sharing of.
Yes. Okay.
Please send the video of Professor Castagna.
And thank you very much, John and Puccio, for inviting me to speak about metal back convertible glenoid component. The journey of the glenoid is a long one, with biomechanical studies leading to clinical evaluation, finding issues, and trying to find new design for better results. The actual real issues in anatomical total shoulder are basically the cuff failure and the poly erosion. Both may lead to glenoid loosening. And it is very clear for many years now, you have a lot of papers there, and you see that Pascal stated we have an issue with the glenoid, glenoid complication represent 1/4 of all complications of total shoulder. However, we have some evidences that in the recent time, the data reported indicated that late soft tissue failures, including instability and rotator cuff failure, are most prevalent, as stated by David Dines and confirmed by, for example, in this registry from Australia, where rotator cuff and instability are the most common cause of revision. Whatever, since 1982 till today, with anatomical revision and revision from anatomical to reverse, if you make a revision, your clinical and functional outcome are poorer than a primary implant. So how we can find an answer to this issue to do better for our patient? The question is, platform systems are helping trying to face this important problem that we experience in the daily surgical life. This is the first report using a conversion system. It was exactly 10 years ago. 34 conversion, AMI to total or total to reverse. We had no complication, poor, very low blood loss, and good clinical results. We were preserving the stem and the metal back component in this study. And after this study, many others came out confirming the same attitude and the same results from other authors. Some clinical cases, and each of those, you can tell, are really caused by the failure of rotator cuff. Top left is recent failure and immediate revision. The other one is a secondary case that is due to preserving the patient and waiting from the doctors that were following him and waiting a little too long. And this is a mistake. You can see that in the left case, when I did immediately my conversion, the polyethylene wear was very minimal. But if you wait too long, you may have a wear that is relevant, you may have metallosis, and of course this may become more complicated as a procedure. And if you exaggerate in waiting, this can be a real disaster. So do not wait too long. This is a lady, my case, bilateral prosthesis. She did well for many years, but one day she came to see us in 2018 with, again, failure of the rotator cuff. We planned to do our conversion at that time, 2018, but the anesthesiologists, they stopped her because she had a very high BMI and healthy problems. Say, you need to come back in 6 months and then we can make it. However, after 6 months or something, the pandemic came and we could not operate on her. And when she came back, it was a real disaster, as you can see in the bottom line X-rays. And waiting too long with metal on metal is not a very good idea, although it was not our choice. It was just very unlucky circumstances. And this is what we found in the revision case, metallosis and poor tissues, blah, 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 blah. So do not wait too much time with this kind of implant. In conclusion, modular convertible glenoids work and allow a simplified revision to reverse, but you must keep your patient under strict clinical and radiological follow-up. And in case of metal-to-metal contact, revision should not be procrastinated. My present trend is to use a blend of it. I use a central metal peg and then all poly glenoid that you can revise with the same principles. We will see if it is working better again in the evolution. So the glenoid failure is a common issue. Revision is becoming more and more common. The gold standard presently is cemented. Uncemented is an option, but new materials and new design may eventually help us from the past to the present and the future. Thank you very much, and I'm waiting all of you for the World Congress ISCS in Rome in early September 2023. Thank you again.
Thank you very much. Alex already mentioned in his last slides the hybrid glenoid. So I would like to ask Thomas Duquin to talk about this new kid on the block.
Thanks very much. It's great to be here, and this is an excellent opportunity to share some real controversial topics in shoulder arthroplasty. So thanks to John and Giuseppe for the opportunity to participate. I'm going to chat to you today for a few minutes about hybrid fixation. So as has been highlighted already, we have a wide spectrum of opportunities for the glenoid today in terms of implant design. And we know that the glenoid really has been kind of the weak link in shoulder arthroplasty over the past many years. So there's been a lot of attempts to try to solve this. So the first question is, what exactly is hybrid fixation? Well, I think it tries to combine the best of both worlds. So we're trying to obtain initial stability through cemented peripheral pegs, but obtain long-term fixation through a porous metal ingrowth center post. And this technique I've been using now probably for about 12 years and have had very good results with it. So we'll kind of roll through a case here of an example. So this is a 68-year-old female, very active, who came in with this pretty standard glenohumeral arthritis. You can see some minor posterior glenoid bone erosion and posterior subluxation. So we'll skip right to the glenoid, skipping all the humeral-sided stuff and talk about the hybrid fixation here. So the first step is similar to what's been highlighted. I do preoperative planning in all of my patients to help getting this placement of the central pin correct. That's really the linchpin part of all of these glenoid operations, is getting the implant in the right version and inclination. And then we're going to go ahead and ream that surface of the glenoid to obtain a full support for the backside. The next step is to prepare for your peripheral pegs. Here we have 3 peripheral pegs and 1 central peg in this 4-peg design. There are other options as well for inline 3 pegs or augmented glenoids. In this particular case, with the minimal bone wear, we're able to do a simple high side ream. We'll go ahead and cement then. And in this case, as was mentioned with the bone ingrowth center post in the previous presentations, we're going to leave the center hole free to allow for that porous ingrowth metal while pressurizing cement into the peripheral holes. So we're going to avoid that cement in the center and then go ahead and impact our glenoid and remove any excess cement. So fairly simple, straightforward technique. And you can see here the post-operative x-rays, which do demonstrate a good cement mantle into our peripheral peg holes, but leaving the center hole for that porous ingrowth metal. And here we did a stemless implant, which is also my preference for our younger and more active patients. So we know it looks good on the x-rays and it sounds great to have this opportunity for early fixation with cement and long-term fixation with metal, but does it really work? So let's take a look at the results of this in the literature. We don't have a ton published on this. This is actually a meta-analysis that was performed published in the HSS journal. They were able to identify 7 studies, all level 3 and 4 evidence, so not any prospective randomized trials, but they were able to identify 3 prospective cohorts and 4 retrospective studies looking at this. They were able to include a total of almost 600 patients with a mean age of 65 and sort of midterm follow-up at 50 months. What they find with this is good improvements in range of motion and clinical outcomes is what we would expect for anatomic total shoulder. The big thing we probably want to question is, what are the glenoid-related complications? How often are we seeing failures or lucent lines or other issues? And looking at this particular series, very low rates of aseptic loosening, so less than 1% aseptic loosening. They did have a few glenoid fractures during implantation. As was mentioned, you got to watch out for that anterior-inferior peg, especially when doing this technique. They had some mechanical implant failures, and this was related to one particular hybrid glenoid design that was on the market that had some dissociation of the metal from the poly. That since has been changed and wasn't an issue with the other implants in the system. They did find an overall revision rate of about 2.5% in this series with regard to the glenoid at midterm follow-up. Another study here, and this is John Sperling's work with Quinn Throckmorton, so the Mayo Clinic and Campbell Clinic, 2 large institutions. doing a lot of shoulder arthroplasty using this hybrid fixation for many years. They went back and tried to review their results with this from 2009 to 2018. They were able to identify 713 patients or shoulders with this technique having been done, with a mean follow-up again of midterm, about 4.3 years in this series for follow-up. What they find again is a very significant improvement in terms of range of motion, function. American shoulder elbow shoulder score is good. So generally really good outcomes from a clinical standpoint. When we go back again and look at their glenoid related complications, very low rates of complications. So overall complications for all causes in this series was 7.6%, but glenoid complications were only 0.6%. So less than 1% of all complications in their series were related to the glenoid. Reoperation rates and revision rates in this series also very low at midterm. And what they found when they looked at their revisions was more than half of these revisions were due to rotator cuff pathology. So it seems as though, at least in Dr. Sperling and Dr. Throckmorton's hands, the limiting factor in shoulder arthroplasty is not necessarily the glenoid anymore, but the soft tissue, the rotator cuff and the soft tissues in the patient population. Their survivorship in this series, 1 year at 98.7%, and then 5 years, still very good survivorship at almost 97% of these glenoids, total shoulders surviving that 5-year follow-up. So in summary, we know that total shoulder arthroplasty is a great operation, and we should continue to do this. The glenoid long has been deemed to be the limiting factor, but we know if we can avoid glenoid complications, we get good pain relief, range of motion, and patient-reported outcomes. With hybrid fixation, it seems that we're able to achieve some of these lower rates of glenoid-related complications, at least at the midterm. Now, we don't have 10, 20-year follow-up on this, so we'll have to see how this plays out with longer-term follow-up. And these favorable results do kind of support this idea that using a peripheral initial cement mantle and then a ingrowth central peg is a great way to obtain stable glenoid fixation. So thanks very much for your time, and I look forward to the rest of the meeting.
Thanks a lot. Appreciate a lot this presentation. Now we have 6 minutes for the discussion. So I would start with the lecture of Paolo Palladini. That is, it focus everything on soft tissue regarding the possibility to improve the visualization of the glenoid. And Paolo, one of the tricks that I use is to cut more bone on the humeral side to have a better approach to the glenoid.
As I showed in the first part of the presentation, is really useful to reduce the dimension of the humeral, first removing the osteophyte and after doing the right cut. I think that at the first time the cut is really important, but doing a good release, you can even do a normal cut, not too huge, and to make the second part, if you need to have an overcutting in the second time, when you need to adjust the prosthesis to the right tension.
And then there is another question from a surgeon that is from Korea. And in Korea, they do not use to do the posterior capsular excision because they are afraid of instability. What do you believe? Is that the risk, having an instability of the prosthesis, to do a huge capsular excision or not?
I know that if we leave the posterior inferior capsule, we have some problem with the reverse prosthesis. Maybe this is not true with the anatomical prosthesis, but I think that this is still my way of proceedings, and I still continue to do the posterior inferior capsular release.
So you never experienced any instability of the shoulder?
No, not for this. I experienced instability of the reverse if we left this kind of posterior capsule, because it's a sort of bridle that can lead to the anterior dislocation.
Okay,
Pietro, what do you think about this? Because a lot of instability is when you insert more retroverted glenoid, not for the capsule stiffness. I think that the problem in posterior instability is retroversion of glenoid.
Yes, for sure. I act in order to see what's about the patient. Some patient you need to do a release, some other you don't need it. So I do based on request of the patient. So it's not a passage that I do always not. That's my experience, but
yes.
Maybe I'm wrong.
Pietro, in this webinar, I like to know about hybrid when you switch anatomical to reverse. Have you experienced about the position of the glenoid, hybrid glenoid? Because it's simple to switch to insert glenosphere, but in anatomical and in reverse, the metaglena is completely inferior tilt, not the same angle.
Yeah.
What do you think about this?
And that's a question about Merolla, because to avoid the loosening of the glenoid, I think it's better to have an inferior tilt, even in a total shoulder arthroplasty. This is because in this way you can avoid sharing forces. And then if you use hybrid kind of modular system, then you can switch very well from a total shoulder to a reverse. So I use this trick to have an inferior tilt even in anatomical. So Merolla, what do you think about this? You put the glenoid component really anatomically, or you do an inferior tilt of the glenoid component even in a total shoulder arthroplasty? Giovanni.
The inferior tilt was a topic that I began to study when I performed research in reverse. We understood that the tilt is important in the reverse. This according to the study of Bolo and others. While all our knowledge about the anatomic, USA and the European colleagues, researchers, teach us that we should create the anatomy as close enough to the original anatomy. So I think that it's not easy to do something on the anatomic similar to reverse. This is my personal opinion. Also, I think that we have not enough data on anatomic to do this type of study, because in Europe we have 80% of reverse. I think that this data will come from our colleague from USA. I don't know if Tom have something to say about this.
Yeah, I think I would agree with you that for my anatomics, I do try to maintain more of a neutral inclination or an anatomical inclination for that patient. Whereas a reverse, certainly we know that inferior tilt is important. With the conversion, I think with some of these glenoids that are modular, that's an important factor. And certainly in metal backs, I think that's maybe one of the limitations of conversion of a metal back is you would have to put the initial anatomic in inferior inclination. And as much as I understand that might be protective in some way, it also probably causes some superior increased force in the glenoid, which may cause erosion of that poly prematurely. So it is a concern in that convertibility. So for the hybrid glenoid, we're able to core out that centerpiece and then reorient it in that inferior tilt for a reverse. So it's revisable, not convertible. But definitely inclination is going to be an important factor, I think, in the next 5 to 10 years as we learn more about this.
Maybe we'll get a comment from Dr. Babukar on another comment on Stemless and where he sees that in his practice going forward, and then we'll move on to our clinical case discussion. Dr. Babukar.
Hi, thanks, John. I think the Stemless is competing with the total shoulder, and the numbers of the Stemless and total shoulders are rapidly going down because the reverses are being done in younger and younger patients, unfortunately, even in my practice. But when I'm dealing with these young, energetic patients, then I think the Stemless is far superior to the total shoulder.
Terrific comment.
Actually, do you use in every case fluoroscopy to check the position of Stemless in operating room?
All the cases. I always have the CIAM. I don't hesitate using the CIAM.
And that's very smart, even for the position. really, before doing any kind of reaming of the glenoid, to check if your guide wire is in the right position. And I appreciate a lot your comment on that. Thank you.
Absolutely.
So thanks a lot. This session is finished. And I think we can move on the next session. John, if you agree.
Yeah, perfect. Pietro and Carl, thanks so much for your wonderful moderation. And next, we're going to work on another session, which deals with a very challenging problem that Dr. Barco is going to help lead the discussion on. And it's my patient returns 3 months after an anatomic shoulder arthroplasty with 3 weeks of drainage and erythema. What should we do about managing this patient in this difficult situation? So let's talk about the infected shoulder arthroplasty and how we would manage that. We got a great panel with us, Professor O, Souza, Tarola, Boileau, and DiGiacomo.
Excellent. Okay. So do you hear me? Hold on.
Yes, Raul.
Okay.
Perfect.
Okay, perfect. So Dr. Dumina will help me moderate this session with me. So let me see if we can see the screen. Do you see the presentation? Okay. So the role was to discuss a patient after an anatomical total shoulder arthroplasty. The thing is that I trained it for a reverse total shoulder arthroplasty, which is basically 80% of my practice. And I actually saw this patient one month ago. And sorry for the noise. So it's a complex patient. He's 60 years old. He's obese, has hypertension, otherwise healthy, and I could say hairy. I don't know if you use a classification for hairiness, but pretty hairy on the chest and the shoulder. So he had a fracture, treated non-operatively. Then someone did like a fracture fixation with K-wires a few weeks after that. And that failed. I don't have the old images, but I did a reverse shoulder arthroplasty in him because he had a bad functioning cuff. So this is his x-ray after taking the staples out. So this was 6 weeks out of the surgery. And this is his image. Otherwise, he was doing well. It was not painful at this point. I used the remaining superior part of the humerus metaphysis, and I introduced the stent through there to preserve the bone stock. So, sorry, that's wrong. That's 3 months after he comes with this wound. It's red. It's draining cerumatic liquid at the bottom of the incision. Still not very painful. Hadn't had a fever. We asked for biological markers, and he has slightly elevated CRP and white blood count. So let's start with the discussion. If this is your arthroplasty, what would you do? What would be the next step that you would at this point do? So, Dr. O.
Yeah, we can consider the chronic infection. And there also we can think about the loosening of the humeral component as well. So I think we'd better check the image, kind of X-rays and CT scans for the stability of the stem and glenoid, and also any kind of the fluid collections on there. So I prefer to check the CT scan for them.
Okay, so what about the drainage? Do you take this liquid and send it to microbiology? Do you aspirate the joint at this point? Do you try to get any samples at this point?
Yeah, I think there's some drainage, and if there's some fluctuations, I can take it out the fluids by using the ultrasound. I can go to the lab for the cultures and microbiologists, I think.
Does anybody in the panel do anything differently at this time point?
I have a question for everybody about this patient. Any exam like ultrasound or CT scan did you do before decide the treatment? Because normally you can find liquid or erosion or something else around the implant or prosthesis in the term of humerus or glenoid. Did you do any other exam?
Also, the question is if an MRI, CT scan, or other exam have a role in this part of the in this stage of the infection. Is it correct?
Yes, before deciding anything of surgery.
Yes, in my experience, there is no role of CT and MRI in this kind of pathology. That doesn't have nothing more than the information that we have. That is my experience.
And Giovanni, you are an experienced arthroscopy. Do you use arthroscopy?
That makes sense. Absolutely. That makes sense because doing the arthroscopy, I can take some 5 samples and can try to make some study on the samples and probably a more precise antibiotics treatment before doing any kind of surgical step.
Oh, sorry. May the arthrocentesis now may have a role in this for this patient?
Raul,
yes,
it's very, very interesting your case because we have in Modena 3 similar cases with Luigi, and the problem is, of course, is sub-infection, but most of the cases is the role of the mobility of tuberosity. In reverse, I don't know, but I think that experience in the faculty, the problem is microinstability of tuberosity and the role of suture. Of course, number 5 fiber wire is useful to fix tuberosity, but sometimes is a site of infection. What do you think about that?
Well, I think it's a site of infection for sure, but I don't think we have a better method of fixing the tuberosities for when we're performing fractures. So, if there would be an alternative, perhaps I would think of it, but I think it's better to try to keep the tuberosities than to use sutures. So I would take using sutures and fix the tuberosities rather than leave them hanging away. The problem with this patient really, and I don't have, this was in another hospital, it was hard for me to get the images. If you look at the proximal humerus, it doesn't look like a very healthy humerus to me. This was pinned, I think, through the skin, and perhaps this was not the best idea. Look in this in retrospect to do this, but he had not many better alternatives. So I really had the suspicion that it was an infection, and I consented the patient to take open samples and take everything out, being very aggressive. And so we did a 2 stages debridement because I thought the most probable agent would be C. agnes. And we obtained 5 cultures. All 5 of them were C. agnes. We left the spacer, and of course the treatment with the antibiotics, a double antibiotic regime. That was, the internal medicine gave them the antibiotics. So how long would you hold the antibiotics? So Stefano, how long would you leave the antibiotics in a patient like this?
Oh, it depends on the blood exam, but 6 weeks according to the new information that we received by the specialist and there's for the infection. 6 weeks, no more.
Yeah. So this was 6 weeks. The inflammatory markers were normalized. We took them away, waited for another 3 weeks. It was normalized. So then we went to the second stage. Does everybody, I think it's 6 weeks minimum. Is that, can we tell that to the audience that 6 weeks for a C. agnes would be like the minimum?
Yes, agree.
Agreed. Okay, so we went on with the reconstruction. The obvious, what are the options? Basically, is we can use metal, or we can use APC like I did, or we can use a monoblock, very long stem. And I took this option because the patient was young. I wanted to try to keep bone in reserve, but this is what I did, and I don't know if it was okay. The case goes on. So I want to know your thoughts on a case that you had previously had an infection. If you want to reconstruct the bone or a missing bone, what would be your preference? So let's go with Luca. What would you do? Luca Tarallo.
Sorry. I have some doubt about the use of plate in the reconstruction of the second implant, because this kind of prosthesis, in my opinion, don't have enough I'd say tenuta touch in the distal part of the stem in the humerus, because you have the proximal part of the stem is the cover of the prosthesis. It's okay for the osseointegration in the upper extremity of the humerus. In the distal part, you have a surface of the stem very, very smooth. So
it was cemented, although we don't see that very well here. I used cement.
Okay. I used them
without a plug, so you don't see the plug because it's transparent. The plug I use, but it has cement. Not a great mantle, I can tell you.
Okay.
But I did use cement.
Okay. The plate is only for increasing the stability.
It's to increase the fixation of the APC to the distal, to the diaphysis. And this is something that has been published by the Mayo Clinic, and perhaps Dr. Sperling can tell us a little bit about that, because they had experience with some 20 cases, I think.
Sorry, Giovanni, I have a question for you. Considering the fact that these patients very often are very, very old patients, which is the percentage in your series of patients with a permanent spacer, and why they decide to maintain the spacer?
Well, that is an excellent question, because it's my experience. Maybe 35 of patients, they arrive at my surgery that are very tired. They most of the time had more than 2 surgeries. They are depressed, and they have difficulty to accept anyway a new complex surgery like the one we are watching now, that anyway has a 20-25% of failure. So sometimes they decide to keep the spacer because psychological issue.
So if I can run through the case, because we have almost...
Yeah, Raul, if you could just show the conclusion, that would be great. We'll move on to the next session.
Of course. So it failed. It was infected again. So the question is when to stop. In this patient, we did a spacer. He was not happy with the spacer. We did successive debridements with humeral bone cuts. It was positive culture in the bone cut until the 4th surgery, until it normalized. So we were losing progressively more bone. We did a PET tag because we suspected that there was some kind of soft tissue pocket that was putting C. agnes in the wound. Finally, after he had a renal cancer surgery, because that we detected with the PET tag, we did this reconstruction that was 15 months ago, and I just saw the patient last month. He was not infected. He is not painful. He has 90 degrees of forward flexion and 20 degrees of external rotation. But so far so good. But this is a patient that might have to go on chronic antibiotic suppression.
Terrific case, Raul. Thank you so much for your sharing this with us, and also the comments of our panelists. Really well done. I think with that, we're going to move on to our next session in techniques in reverse shoulder arthroplasty, tips and essential steps. And we're so fortunate to be able to have Professor Boileau and Dr. Fiumana help moderate this session. And our first talk is going to be Professor O, who's going to share with us how to tension the reverse shoulder arthroplasty. And with that, Roberta, if you can please bring up Professor O's presentation, that would be terrific.
Thank you. I will run my pre-recorded video.
Sorry, Prof. O, you didn't share the audio.
So maybe, Professor O, you can speak over it, please.
Sorry?
So if you can play the video, Roberta, and Professor O can speak over the presentation, please.
I think it's better to run my, yeah. Hi. Thank you. Let's talk about how to tension the reverse. Two extremes of proper tensioning is instability or acromial stress fracture. Low tension is related to instability, and that is related to proximal humerus or glenoid bone loss or subscap problems. High tension is related to over-lengthening and related to pain or acromial stress fracture. Let's consider why we do reverse. According to my data, to overcome the pseudoparalysis, deltoid lengthening, and medialization of center of rotation is necessary. Many papers said that arm lengthening around 2 to 2.5 centimeter is needed. So I do routinely use stress X-ray preoperatively to measure the fixed head elevation exists or not. Operatively, soft tissue release is essential. Not only pec major release, sometimes latissimus dorsi release. Capsular release is really important, anteriorly and posterior side. Sometimes more humeral neck cut is needed, but it's better to save the remaining infra and teres minor insertion. Forceful trial reduction and dislocation can lead to fracture or implant failure, so probably you have the several ways of intraoperative tensioning procedure. Most common one is shock test, traction along the longitudinal axis. Other is bad shuffle test, is to recreate the action of weight bearing via the elbow, so adduction and extension, and give proximally directed forces. Lateral thrust test is using your index finger laterally directed force to displace the proximal humerus of the glenosphere. My usual way of the intraoperative reduction is snap fit reduction variant. I don't do any trial reduction, but during my trial reduction, if I can see half of the glenosphere, that's my proper tension. If it's really easily reduced, I build up. It's difficult to reduce. So if I cannot see any glenosphere, I deeply, a little bit more insert the trial stem and rim down the proximal humerus a little bit more and try again to trial reduction until I can see half of the glenosphere during my trial reduction. But instability and acromial stress fracture is not only the problem of tension, so it's better to look for all factors to contribute to instability and acromial stress fracture. Those factors must be identified to prevent, to fix the cause according to patient. Let's talk about low tension and instability. Subscap repair is essential, especially in the Grumman type traditional reverse. But lateralized implant, subscap repair would not be essential in terms of stability. Anatomical implantation is really important for proper tensioning. It's my patients delay dislocation more than 10 times, even after 2 revisions of build-up. Carefully check the cause of the dislocation. Upward insertion of base plate, about 25%, and antegrade insertion of humeral stem. Notching, gonna be the cause of the instability. Get my patient of
Looks like the video stopped, Roberta. If you can restart it, or you can continue it, please.
Roberta.
It's good until 3 years. Dislocation happens inferiorly after 3 years after surgery. Serial X-ray shows the progression of the notching and the inferior dislocation happens. Let's talk about acromial stress fractures, high tension. As we already talked at distalization, high tensioning is the cause of the acromial stress fracture. But lateralization, there is a debate that probably is not the cause of the stress fracture. Female osteoporosis, rheumatoid arthritis, and also previous surgery, failed cuff repair is the cause of the acromial stress fracture. CA ligament is really important for prevention of stress fracture. Several papers says that preservation of CA ligament is really important to prevent acromial stress fractures. So please do not do CA ligament release routinely. Another factor of the acromial stress fracture is peripheral screws of base plate. Not only superior, but also posterior screw is important. Look at my patient. Patient is happy with 1 year of surgery, but scapular spine fracture happens. And look at these screws on the posterior side of base plate. That is related to stress fracture of the scapular spine. For the low tension, so-called instability, soft tissue tensioning is really important. It can be controlled by approach, bone graft, or subscap failure, or subscap repair. So we can adjust the soft tissue tensioning with the humeral side. Implantation should be anatomically implanted. So lateral implant going to be safer in terms of instability. Notching should be prevented. High tension versus, the acromial stress fracture, the over-lengthening, over-distalization cause the acromial stress fracture, but lateral prosthesis is going to be the safer than distalization. Another cause of the acromial stress fracture, female, old people, osteoporosis, or the previous cuff repair. So serial changes of X-ray is really important, and check the acromial tenderness every follow-up visit. Proper surgical technique, including the base plate screws, not to, especially for the superior and posterior peripheral screws, and do not CA ligament release routinely. Thank you very much for your attention.
Bye.
Thank you very much, Dr. Hu. And now is the speak to Dr. Barco from Madrid. Speak us the importance of subscapularis repair in reverse shoulder arthroplastic, and is important to repair or not repair. Thank you.
So I will share my screen so I can go over the presentation. I will share it now. Okay, so I will go over this talk. Let me use this. Okay, so some biomechanical reasons to use or not to do the repair of the subscap. Some of the clinical outcomes are my personal recommendations. So obviously, in rotator cuff arthroplasty, there's not always a subscap. So I think that's not the case. This is the case that we are discussing. Those cases where you implant a reverse shoulder arthroplasty and you have a good subscap that you can repair, and should you do it or not? We know that Edwards showed with a Grammont design that the risk of instability was doubled when you did not repair the subscap. But Clark with the DJO system, a lateralized glenoid, and Friedman with a lateralized humerus design showed that with repair, there was a low rate of instability. Biomechanically, repairing the subscap is unfavorable because it opposes the force of the deltoid because it works as an abductor until 80 degrees of abduction. And this is similar with any kind of design, medialized or lateralized. It is also, if we look at the horizontal forces, if you repair the subscap, the posterior cuff forces to maintain neutral rotation are obviously increased. And if you pull more on the subscap, the more forces you need to increase. We know that with the implants we use nowadays, with lateralization, there is better tension of the remaining cuff, and the delta wrapping effect increases the joint load angle such that if you're lateralizing, it almost equates to performing a cuff repair regarding stability. This is the best evidence. This is 3 meta-analysis and systematic reviews, and I will summarize the information. First one says dislocation rates are decreased when you repair the subscap, but no difference in clinical scores. In 1,300 patients, we see again lower dislocation rates with repaired subscap, but if you do not repair the subscap, a lateralized center of a lateralization of the implant will reduce the dislocation rate. And a third meta-analysis has shown that you even improve the clinical scores, the constant scores and ASES scores with a repaired subscap. So this is the implant I use, and this study, so you might want to look at the specific implant you use because you might get some specific differences. In this one, no difference in clinical scores, less dislocation with repair of the subscap. This is a greater, larger study, so almost 600 patients, and again, less dislocation with the subscap repair. And again, this is something very important, higher postoperative scores with the subscap repair, and more internal rotation, active external rotation, and strength. This is a study performed at 2 years, and the question is, will these results translate into the 5 years? And it does. Again, low dislocation rate, but again, the subscap repair group has increased simple shoulder test and increased internal rotation, which for me, it's very important, and external rotation. You might think, of course, this is rotator cuff arthropathy patients, but in this study with patients undergoing reverse with an intact rotator cuff, again, the group with subscap repair, no difference in complication rates, no difference in dislocations, but better active forward elevation and internal rotation score. But this did not reach the minimal clinical importance difference. But if you do suture your cuff, your subscap, we know the results are better in internal rotation if this heals. So protect your patients. For discussion, we know biomechanics and life are a different thing. There is certainly more instability without subscap repair, but it might be not very significant. There can be small differences clinically, but this needs probably be analyzed on design per design. In this design, I use all metrics were improved with more subscap repair, except forward flexion and abduction, but it does have the potential of improving internal rotation. So for me, I repair it first if there is one, if it has no tension, if it has good quality, and the patient has external rotation greater than 0. And if you repair it, you should protect it. Thank you.
Thank you very much, Dr. Barco. Then let's talk about Stemless reverse arthroplasty, Professor Gumina from Rome.
Yes, thank you. Can I have the pre-recorded video? Thank you, Giuseppe and John, for this kind invitation. My current first choice of inverse prosthesis is the short stem one. However, the reverse stemless has a specific role in my practice, and my experience with stemless prosthesis begins in 2004 with the TESS prosthesis. Which are the possible advantages of stemless? This is what the literature reports. The main benefits are the immediate preservation of a humeral bone stock. Toward the preservation of the bone stock, and we know that potential stress shielding in the proximal humerus may in part be reduced using a shorter humeral stem. Compared to what happens for stemmed or short stem, neck shaft deformities can represent a minor problem.
decreased in intra and post-op periprosthetic fractures. And finally, only theoretically, they should be easier to review. I totally agree with John regarding the absolute and relative contraindications of stemless prosthesis. The real disadvantages of stemless reported in literature continue to be dependence on proximal bone stock, reliance on subscapularis repair, and technically demanding, in particular, what angle of the humeral osteotomy. 2 weeks ago, Frankel, at the Berlin shoulder course, said that the humeral head osteotomy dictates the size of the core. Moreover, the osteotomy can lead to various biomechanical problems whose resolution becomes difficult. You know the implantation technique, the subscapularis sternotomy, the removal of osteophytes, humeral head resection using the external guides. We don't use the intramedullary guides. I make the final decision whether to put a stemless reverse intraoperatively. I call it the thumb test. I have to ascertain whether the cancellous tissue is compact and resistant. There must be no cystic areas or pathological areas. And I'm very happy to have seen that John, in his beautiful video, does the same things too. Determination of stemless core size, the humerus preparation, and the final implants. This is my evaluation error, but the patient is fine and has no problems after 4 years. And this is another mistake in my series of inclination and height, but even in this case the patient is fine. This is a fracture during the impaction onto the lateral cortex. This is a case of mine during an implant more than 15 years ago. This is my recent series. The average follow-up is 4 years. I eliminated the anatomical stemless, and as you can see, the indications were mainly for rare calf-tear arthropathies of young patients. And this patient will soon have to undergo surgery on his right shoulder for the same reason. He has pain of marked intensity, and I will definitely implant a reverse stemless on the right shoulder. And these are the literature data relating to reverse only. With stemless humeral components, instability may theoretically be more likely to occur because of more limited options in positioning implants, height, and complexity in humeral resection, owing to reliance of metaphyseal fixation. The published complications rate for stemmed primary reverse total shoulder arthroplasty is approximately 15% versus 11% stemless. And stemless loosening 0.2%, and the rates of radiolucence lines varied from 0 to 60%, depends on the follow-up, and the scapular notch from 0, follow-up 14 months, 72% follow-up more than 8 years. The conclusion. Frankel believes that reverse stemless prosthesis is a bad idea. I don't know. At midterm, stemmed versus stemless implants provide comparable results. Long-term results, we have a few studies, are now available. Revision of stemless is theoretically easier, It currently has precise indications, but it's probably that in the future they will extend. Thanks. I really appreciate your attention, and I look forward to seeing you in September for the ICS-ES.
Pascal?
Yeah, thank you, Stefano. The next talk is about reverse arthroplasty with a stem humeral component by Dr. Irner. Please.
Thanks, John and Giuseppe, for asking me to talk. I was hoping that they could put up my prepared presentation video. Thanks.
Yes. Just 1 minute.
The reason for that, it's very late in New Zealand. It's 2 a.m. in the morning.
Oh, poor guy.
We appreciate you being here. Thank you.
Grazie mille.
Part in this conference. When we perform a reverse shoulder replacement, our primary objective is to relieve the patient's pain and to improve their functional outcome, and this is by improving their forward elevation and rotational movements. In addition, we are trying to perform an operation that has low morbidity and good long-term prosthetic survivorship. We're trying to preserve bone and reduce the incidence of complications such as dislocation, stress shielding, scapular notching, acromial fractures, and infection. By using a modern contemporary design that allows for some degree of global lateral offset, we're able to achieve most of our objectives. Initially, in order to improve the lateral offset on the glenosphere side, we used a bio-RSA or metal. We also learned that we needed to place the metaglene along the inferior aspect of the glenoid and to increase the offset to the glenosphere, and this reduced the incidence of scapular notching and improved the patient's rotation. However, as we learned more about the anatomy of the glenoid and specifically the beta angle, we realized that we were probably placing the glenosphere and the center of rotation too medial, and as a result of this, in the majority of cases now, I will use an augment to prevent over-medialization of the center of rotation. However, if you do use an augment, this automatically increases the lateral offset, and you need to take this into account when you decide what humeral configuration to use. The optimal position of the greater tuberosity is probably at its origin, and this provides the greatest amount of rotator cuff tension, the best deltoid wrapping, which brings into action the anterior, middle, and posterior deltoids, which act effectively as rotators. The lateral offset on the humerus is determined by the distance from the pivot point to a line parallel to the humeral shaft, and the humerus comes in a number of different configurations from 135 to 145 degrees and 155 degrees. You can use an inlay, onlay, or hybrid design. In the onlay and hybrid design, the pivot point sits above the cut surface on the calcar area. There's also been an evolution in stem design. We've moved away from using long stems, which engaged the diaphysis and had a tendency to remove a lot of bone and also cause stress shielding. And we're now using more mini and micro designs, which have a greater ability to preserve bone, up to 54% when you use a micro design. Not all micro designs are the same, and if you are going to use one, it should be porous coated proximally, because this is where you want all the bone ingrowth to occur. It should be polished distally to avoid any bone ingrowth. A wedge design helps prevent any subsidence, and a fin provides good initial stability. It's important to look at the stem that you're using, specifically the shoulder, as these round shoulders don't provide very good initial stability, and certainly not as good as these two designs. The canal fill ratio should not be more than 80%. If you do fill the canal excessively, this increases the incidence of ingrowth and proximal stress shielding. If you're using an onlay design, it's better to use one that has a collarless design, where the actual collar sits off the cut surface, and this does enable subsidence if you undersize the stem, but more importantly, it provides for better load sharing in the metaphyseal area, which reduces the incidence of osteolysis and stress shielding. If you do increase the global or the lateral offset on the glenoid side, and you want to reduce the amount of humeral offset, you can use 155 or 135 degree stem, but this increases the risk of notching or potentially dislocation with 135 degree stem. If you use 140 with an onlay design, you can actually reduce the distance between the pivot point and the stem by offsetting the tray, and this reduces the degree of lateral offset on the humeral side with this type of configuration. There are pitfalls associated with using microstems, and you can place these in excess of varus or valgus, especially if you're trying to undersize the stem and not overfill the canal. I get away with it. I try and prevent this from happening by making sure that my entry point is as lateral as possible. I use a long reamer, and I cut off the long reamer to make sure that I get the angle on the humerus perfect, so that when I do actually place my stem, in my case I use an onlay stem, it doesn't tilt the stem into a varus or valgus position. I think that generally speaking, if you use a modern contemporary design, this allows an element of global lateral offset, which provides the patient with excellent pain relief and function, low morbidity, and good long-term survivorship. Thank you.
Thank you very much. And the next talk is now Dr. Ducking from Buffalo, who is talking about management of glenoid bone deficiency with reverse shoulder arthroplasty.
Thank you, Professor Boileau, and again, John and Giuseppe, for the opportunity. We're going to spend a few minutes here talking about the glenoid. I love that we're talking about the humerus here in reverse, because I think that that's something that's been less conversed. The glenoid we've certainly known to be an issue. So again, glenoid bone loss, I guess the first question you might ask is this really a problem for reverse arthroplasty? And I think we've shown that it's true. Probably about 40 to 50% of patients undergoing reverse arthroplasty do have some degree of glenoid bone issue that needs to be addressed at the time of the operation. So as we've talked already fairly extensively and heard from multiple of our faculty here, the first tip is plan your cases. The only way to really be able to understand your glenoid anatomy is to do preoperative planning, and this is really critical to obtain a good result in your reverse patients. We know that this has been described, preoperative planning, in multiple different ways, but has been mentioned now. 3D planning is really the gold standard. I think everybody should be doing this 3D planning software, and there's plenty of them available on the market, and all have certainly benefits towards understanding the anatomy and the position of our implants, and gives us the opportunity to actually perform the surgery in the virtual world before the real world, which should help to improve your outcomes. So identifying the problem is only half the battle. We have to figure out actually how to manage this problem and treat it though as well. So let's talk for a few minutes about the techniques. The first question I asked with this is, well, how much support do we actually need for our base plate to be stable to allow for osseous integration? So we looked at this in our biomechanics lab using a polyurethane bone foam and looked at 4 testing groups. And with this particular implant design, what we see is there's a significant change as we get from 75% to 50% contact groups. So anything less than 75% surface contact with this implant will result in excessive micromotion that might cause issues with stability. So we know we have to get base plate support of at least 75%. So now how do we do that? Well, we can high side ream, obviously the glenoid down to obtain that contact. We can bone graft it, or we can use a metal augment, as been mentioned previously. So let's talk about each of these individually. High side reaming certainly is what we've been done before. The challenge with this is it does further medialize that center of rotation. And we've talked about all the benefits already of potential lateralizing in terms of improving our biomechanics and range of motion in the reverse. It also results in removing the best quality bone. So when these implants are placed, they're placed on the softer, more cancellous bone that might be a risk for fixation. So in general, for anything outside of a very small bone deficiency, we're probably not really considering high side reaming any longer. Bone grafting is certainly something that's been well demonstrated in the literature in terms of techniques with this. And this can be done using a variety of different graft options. Obviously, the most common being the humeral head is being in the primary shoulder arthroplasty. But in revisions, there's other options as well for distal clavicle or iliac crest or even allograft sources. And there's different techniques for this, but generally you're using bone to fill that defect in a structural manner. and then fixing that either with screws within or outside of your base plate. The bone grafting results, this is U.S. literature from the Rothman group, fairly experienced surgeons looking at this, and this is structural bone grafting in patients with bone deficiency. What they see is about a 25% radiographic loosening rate. So there are concerns with graft issues using bone grafting, at least in this series, in terms of causing early failure. The bio-RSA is another technique, and Professor Boileau certainly taught us extensively about this and all the technique in terms of how to be successful with this, in terms of how to do this. And now with the angled bio-RSA, certainly an option for being able to address these bone deficiency cases as well. The results of this, generally have been good. So this is a publication from their group looking at long-term follow-up, so 5 to 10 years, significant improvements in patient-reported outcomes, high satisfaction rates, and 96% survivorship. I think the concern still on this population might be the notching. As you can see, about 18% of these patients still had grade 3 and 4 notching, so something that might be better with newer techniques. Glenoid bone loss in terms of augments. So this is something that's been around for the past several years now, is using metal to fill this defect. And certainly there's lots of different designs on the market. There's full wedges, half wedges, and now even some companies are purporting this idea of a patient-specific or patient-matched glenoid, so using metal to specifically treat the patient's deformity. These are at least theoretically able to obtain stable fixation with less bone removal and able to maintain that lateralized position and prevent scapular notching. So we looked at this in our lab again to answer that question. Does the augment actually restore stability of the base plate, at least at time zero biomechanics? And what we find is the answer is yes. So using an augment in a bone deficiency model does resume or restore your base plate stability in this case. So augments, certainly at least in the biomechanical sense, can give you the stability that you're looking for. What about clinical results? Well, a little less in the literature for clinical outcomes and augments, probably because they haven't been around so long, but there's 2 retrospective reviews that have been published on this in the literature, totaling 112 patients, again, showing good clinical outcomes, only 1 case of aseptic base plate loosening, and the scapular notching rate, at least in this short to midterm follow-up, was 6 to 10%. Our own data, so from the University of Buffalo here, looking at our patients, we did a matched control trial looking at 98 non-augmented and 106 augmented glenoids with minimum 2-year follow-up. We found there's really no base plate loosening in either group. Generally good patient-reported outcomes. There was no significant difference between the groups in terms of outcome. We did see less notching and improved at least lateralization measurements in the augmented group. So from at least a biomechanical and notching standpoint, maybe an advantage of using the augment. This is one last study that has recently been published in the Bone and Joint Journal just in 2022. This was a systematic review, a meta-analysis trying to look at the question of augments versus bone grafts. They were able to include 13 studies with almost 1,000 patients with a mean follow-up of 40 months. They broke it down into the 2 groups of bone grafting versus augments. And in the bone grafting group, they were able to include 9 studies, almost 300 patients. And again, 93% graft union rate, fairly low rate of complications at 8.9% and only a 2.4% revision rate. In the augment group, there was 5 studies, included 627 patients, 3.5% complication rate and 0.6% revision rate in these groups. So in summary, we know that you can get good outcomes in terms of management of glenoid bone loss. You do have options, whether that's bone grafting or the use of metal. We see improved outcomes with both. Based on this systematic review, there was slightly higher improvement in the American Shoulder and Elbow Surgery score in the augment group compared to the bone graft group. And there was a low complication rate in both groups, but a slightly lower rate of complications with augments and lower rate of revision with augments compared to the bone graft. So for me, my current practice is, again, doing CT scanning on everybody with preoperative planning using 3-dimensional software. I get PSI cases in situations of significant glenoid bone loss where I am concerned about the ability to position my implant appropriately. And then I use augments, in all cases in order to address these bone deficiencies in order to obtain stable fixation with our implants. So thanks very much for your time and look forward to the conversation.
Thank you very much, Dr. Duckin. So there are some questions for the audience. And the question, I think, is for Dr. Barco and the importance of the subscap repair. There are two questions. One about the position of
Gabriel, I think you have some feedback going on.
Sorry.
I think.
And I think Professor Bolo can speak.
Yeah. Why don't we do that? That'd be great.
Okay, so we can talk, yes, start with the subscapularis repair with Dr. Barco. There are many reasons to repair the subscapularis in reverse shoulder arthroplasty. The ones that you mentioned, of course, improve internal rotation, improve stability. I think there is one other reason that is rarely or never mentioned. For me, it is the fact that when you reattach tendon and muscle to the bone, you bring vascularization, which means if you read the paper of Barbara Melis and Gilles Walsh about the resorption of the bone of the proximal humerus in reverse shoulder arthroplasty, this is something that happens and that will happen in the future, not solved yet, even with stemless or short stem prosthesis. There is still possibilities of proximal bone resorption of the humerus. And I think another reason to reattach the subscapularis for me is to bring some vascularization to the proximal humerus and also, of course, to prevent infection. This is never mentioned as well, but the more soft tissue you are around the metal and the plastic, and the less chance you have to have this kind of complication. So I would like to have your comment, Raul.
Yeah, I completely agree. I was focusing more on the biomechanical aspects and of course in internal rotation, which you always learn from patients. I had a patient with a single arm because he had a deformity and he had I implanted a reverse. He had very good forward elevation, but he was not able to have internal rotation, and he was miserable. He was crying in clinic. And from that day on, I focused very much in gaining internal rotation. And I think it's been shown that, we know the subscap is an internal rotator, so I try every time to do this. We know that it is not always there. Sometimes the soft tissue quality is very bad, and perhaps in these cases, we don't get the effect of improved vascularization because it's a very thingy tissue. But I try every time. The problem now is that as we are using lateralized designs, sometimes you have a lot of tension. And so you have to be very careful with your releases, take a little time in preparing this.
So don't you think that the fact that now we do glenoid lateralization and now some surgeons do humeral lateralization because of the design of their implant is a mistake to have both? I mean, you must choose one. At least this is my philosophy. I choose glenoid lateralization, but I don't want to have humeral lateralization because for me, one criteria of good lateralization and good distalization is when I'm able to repair the subscap. If I'm not able to repair the subscap, I know I'm wrong. What do you think about that?
Well, I agree. That's why my glenoid is medialized, but I use a lateralized humerus design. So I'm lateralizing on the humerus instead of the glenoid. But for me, it's also very important to have this subscap inserted.
Okay. Let's talk about the tension of the reverse prosthesis with Dr. Ho. I saw, Dr. Ho, that you do intraoperative trials to see if you are well tensioned, but how do you know that your patient is has the same anesthesia from one patient to another? How can you control that? It depends on the relaxation, muscle relaxation of the patient, and of course, it depends on the depth of the anesthesia of your patient. Any comment?
Yeah, that is true because the patient is sleeping and patient's muscles are relaxed, so it's really difficult to measure the proper tension by the palpation of muscle tension and so on. So it's better to have the definite, the objective, the measurement is lengthening of the arm around 2.5 centimeters. There's a proper lengthening of the arm. And also, I think my trial is I'm trying to reduce it. If I can say half of the glenosphere, I think that's a proper tension for me. So I've never experienced of kind of instability or the really high tensions. So that's my tips for my trial reduction for that. But okay. Muscle tension, I think that's not that important. I think so.
Pascal, can I do a question?
Sure.
Oh, I have a question for my friend Yo. When you put your liner, the trial of your line, do you reduce the prosthesis or you only check the tension of the soft tissue?
The trial, I mean, the tray or the pulleys are really important. Not only nowadays, most of the company has the eccentric trial. So it's better to pick up the proper trial, I mean, the proper tray or proper pulley in terms of distalization and lateral or a little bit more medial. So eccentric tray usually give a little bit more distalization with a little bit medialization. So not only tension, but it's better to think about medial versus lateral with the choice of the tray options, I think.
Pascal.
Yes.
For me, it's very important, not only subscapularis and deltoid, but in 10% in literature of painful reverse, the problem is conjoint tendon. With Fumana, is a physiotherapist of my group, we have a lot of attention. We pay attention of anterior pain. What do you think, the faculty? What do you think about that?
In my experience, the pain related to the conjoint tendon may be related to the overtension, over distalization, but in fact, it's very rare. The problem is that when you have cuff arthritis, you have excessive crown of osteophytes around the humeral head. And I think the key point is to avoid impingement between the proximal humerus and the conjoint tendon. For me, this is what I found, which was creating the pain. And this is why I take some time during the surgery to remove the osteophyte on the lesser tuberosity, for instance, if they are everywhere around the head, because this is I don't want to have impingement with the conjoint tendon. The other thing is that I pay attention to put my base plate and my sphere posterior enough. You know, the problem is always the exposure of the glenoid, and there is a tendency for the surgeons to put the base plate and the sphere a little too anterior. So the two things that I recommend is to put the base plate posterior, inferior with the sphere, and to remove all the osteophytes on the humerus and to check that there is no more impingement between the proximal humerus and the conjoint tendon.
Very interesting. Have you noticed, have you experienced about pre-operative CTA, the real CTA? When you have CTA against the acromion and you distalize, is a completely different tension because you have the humeral head upward and you distalize a lot the humerus. The faculty has experience about that because, of course, too much tension, but it is necessary to implant the reverse.
If I can start to answer. Go ahead.
Yeah, I have an experience, a really small lady, a little bit over-lengthened. The patient has a little bit pain on internal rotation and also has the cricoid stress fracture. Probably small lady, so a little bit, it can be acromial or conjoint tendon tractions by this over-tensioning. I agree on that. Thank you.
Can I just say something? I know everyone's talking about acromial stress fractures and coracoid stress fractures, but I think if you look at the literature, no one really knows the cause. And there's been an interesting article that's just come out in Australia by Sumit, who's actually shown that they think that there's a pre-morbid condition of the acromion prior to patients having a reverse, that they've got a weakened area in their acromion before they have a reverse. So, and as far as I'm aware, in all the studies in the literature and all of the reports, they're all underpowered. No one really knows the cause of the stress fracture. So to say it's over-tension and everything when you have one case or two cases, I'm not convinced that you can really say that. Coming back to the coracoid problem, I think if you think that the patient's over-tension in the coracoid, in the conjoint tendon, you can give them local anesthetic to see if that is the case. But I actually agree with Pascal. I think that it's an impingement problem rather than actually over-tensioning, because over time, I always check the conjoint tendon to see what the tension's like, and it's variable. And I don't have patients having lots of pain, but I've got one or two patients that, and I can think of one particular patient who's definitely impinging.
I think we must distinguish between the acromial fractures and spine fractures, which are very different. Acromial fracture, if it happens, sometimes it's a fatigue fracture, and there is no consequence of this, just a plication of the acromion. The real problem is the spine fracture, and people think it's because of the screw, which is true. The screw is creating an area of stress riding, but in my experience, at least I have two patients where I know exactly that this spine fracture was not related to overtension, but was related to over-abduction and impingement. One lady told me the story that the physiotherapist took the arm, put him in hyperabduction, and then she had a crack in the spine fracture. So this is a different story, and I'm not sure we are right when we think about that.
Great discussion and great comments. I think with that, we'll move into the next session that Tom DeQuinn is going to help moderate. And Tom, I think you're going to share with us another challenging complication, the patient who has the dislocated reverse. We have a great panel to help us discuss this with Dr. Weiser, Herner, Babukar, Campi, and Fiamina.
Thanks, John. And, in true fashion, I think we often will learn more from our mistakes than from our successes. So we're going to roll through a case here. Unfortunately, my co-moderator, Fabio Conti, is unable to be with us. So we'll proceed forward and look forward to the comments from our expert panel here. So here we go. Here's our expert panel, as Dr. Sperling said, and we're going to, move right into the case. So this is a 63-year-old male patient. He's a little bit obese, so 300 pounds, 6'2", BMI of 39. He comes in with these x-rays, which you can see here, showing advanced shoulder arthritis with collapse, possibly a component of AVN. And I didn't include in his history, but he is a bit of a drinker on top of all of this. So he has some loose association with alcohol, as we might say. So we did proceed forward with this reverse total shoulder, which you can see here with the implants. And then basically right in line with the story that they gave me to follow. At 2 weeks, he came in actually doing great, wearing his immobilizer, no problems. He started working with physical therapy at this point. And then at 5 weeks post-op, he shows up to the emergency department with acute onset of pain and deformity. So I think we'll ask our panel here, Mark Herner, so what do you think at this point, patient presenting to the ER, acute dislocation, what do you want to do in terms of evaluating this patient, or how are you going to try to manage this problem? You're on mute, Mark, so maybe unmute yourself.
So I think for me, actually, this patient is the highest risk patient. He's morbidly obese and he's a male patient. So I think the planning, actually, I probably would have been a little bit more careful with the planning for this patient because he's very high risk of dislocating. I think now that he's presented with the dislocation, in the first instance, I normally just do a routine, just check, make sure they don't have an infection. But in the immediate period, I would take this patient, I'd check if they've got an axillary nerve palsy, what the axillary function is, and then treat the actual problem initially. So I normally would reduce this in the operating room. I don't think at this stage I'd have all the components available if I wanted to do a revision or anything specific. So I'd take them to the operating room, reduce it, test their stability under anesthetic, and see whether they're stable, whether I can pop them in or pop them out. And then once they've actually been reduced, I then have the next day, if they are stable, I then have plenty of time to actually evaluate them further. If I think it's going to be an ongoing instability problem, which I suspect in this patient it probably is going to be an ongoing problem. I think this patient's going to have, he's going to come back and it's going to dislocate again. But I think there are a few technical aspects to this. But I'm sure there are going to be questions for everyone else, but that's just my how I would initially treat this.
Okay. Dr. Weiser, any role for closed reduction? So we did pop him back in the ER. His exam under anesthesia showed that it was, relatively stable through a range of motion, wasn't easy to redislocate. So is there any role for closed management of dislocations of reverse, or is this always something that needs to be revised?
Thanks for this question. First of all, I have to say I fully agree with Mark. I think this patient is at high risk. I'm not really sure. You showed he has a BMI of almost 40. He might have diabetes. If you see a humeral head necrosis like this, I always am a little bit concerned about some neurological problems as well, especially with this alcoholic abuse. Coming to your question, I think, yes, I would also try to make a close reduction. And we looked at our series of dislocated shoulders, dislocated reverse, and we found more or less a success rate of about 50%. After close reduction. So I think it's worth to try it. And if you fail, you will figure out anyway, and then you have to do some kind of open revision.
Any other workup at this point, Dr. Weiser? Any CT scans, or as Mark suggested, are we aspirating this joint looking for infection, or are you just going to pop it in and see if closed management works half of the time, like you said?
Yeah, I think at this point, if you don't have any signs of infection, clinical signs of infection, I think I would just go for the closed reduction. Then I would wait. I would maybe brace him, put him on an abduction splint or a neutral brace to protect him. If he comes back, and if I need to go for open revision surgery, I definitely go for aspiration, because we also have seen that there is quite a strong correlation to infected joints. Okay. And then I would do a CT scan and an aspiration.
Great. So that abduction brace, how long would you keep them in that for your closed treatment?
4 to 6 weeks.
4 to 6 weeks. Okay, great. All right. So that's what we actually planned. And he came back within 2 weeks, again, dislocated, as you might expect. So he presented again now to the ER with dislocation. This time it was rolling over in bed. While he was sleeping. He reports he was wearing his immobilizer, so we'll believe him at that. And now he's dislocated again. We did have them pop him back in just for purposes of not leaving him out for too long. So what now? So Dr. Babukar, what are your thoughts here? What other additional workup might you want? And then what would your sort of plan be for this patient?
So Thomas, yes, nice, very interesting case. I'm a little intrigued why PT was started so soon and early. Each one his own case, but in my practice, I would start it only at 6 weeks. With his obesity and alcohol again being unreliable, I would still need a little bit of information. I think the glenosphere is on Mark C, is it? So what's the subscapularis?
I think we're having a little problem with your audio.
So are you able to? Yeah. Can you hear me?
And now we can, yeah.
Yeah, did you repair the subscap?
We did repair the subscap at the time of the first surgery, yes.
First surgery, yes. So this superior migration could be either he's catching underneath the glenosphere, or perhaps he's too tight. Usually after my reverse shoulder, before I do the closure, I measure the tightness of the conjoint tendon. I arbitrarily label them between 0 and 5 just as a scale to know how much tight I've done. It doesn't help me in the case, but when things go bad, I can always go back to notes and find out this is where I will start doing it on either sides, and then the versions.
Yeah. Okay.
And the version.
Yeah, we lost. Yeah. So I'll kind of summarize. Yeah. So we did, work this up. No signs of infection. I didn't do a formal infection workup in this guy. At this point, we thought that this was probably more of a mechanically related issue. But after a second dislocation, certainly we are going to plan revision. So, Dr. Campi, what are your thoughts in terms of techniques for revising an unstable reverse, whether it's yours or somebody else's? What's your process?
Dr. Campi is not present, but the problem, I make a question, which is the reason of instability. The tension of deltoid, the problem is because for me, in my experience, or I want to know your experience, early dislocation or late dislocation. The problem in early is mechanical reason. What do you think about that?
Yeah, I would agree 100%. And as was mentioned, this guy is high risk for instability. I think you can see just from the x-rays here, the soft tissue shadows. And he has one of these phenomenon with, kind of fat in his axilla, where even as he comes down into adduction, it will cause a lateral distraction of the implant, which I think predisposes these patients with obesity to instability. So this was a case, very early in my practice, probably before I recognized that. And these patients now, I think you absolutely have to lateralize on the glenoid side in order to prevent this problem. Addition to that, we did take him back for revision, and what we found is another source of instability as well. He had some posterior bone, like a posterior osteophyte that we never removed in the primary surgery. So he had bone posteriorly extending beyond the glenosphere, which was causing impingement. So he actually had probably two causes in my mind for mechanical instability. The first being the lack of soft tissue tension for lateralization due to his body habitus. The second being a mechanical impingement on the posterior part of his glenoid that was probably encouraging this dislocation event. So we went back and revised him. We did both increase the diameter of his glenosphere. So we went from the 36 to the 41. And then we also increased his lateral offset and increased his inferior offset. So we tried to add more soft tissue tension, both in the medial lateral plane as well as superior inferiorly, and then added a larger glenosphere. And that's his x-rays post-revision. Yeah.
What a great case. Thanks for highlighting some of the critical issues to think about in the unstable reverse. Really well done. Appreciate the panelists' comments as well as some of the attendees. I think with that, we're going to move into our last session now on complex and revision shoulder arthroplasty, how to manage your most challenging cases. And Professor O and Professor Tarallo will go ahead and moderate this session. Again, we're very fortunate to have Professor Boileau first lecture, which will be reverse arthroplasty for fracture. He's taught us a tremendous amount about how to manage these challenging cases. So with that, Roberta, if you can run Professor Boileau's video, that would be terrific. Thank you.
Excellent. And now I'm placing...
So good afternoon to everybody. So we started with the first presentation of Professor Boileau about the reverse arthroplasty for fracture.
Can you start the pre-recorded talk, please?
Roberta?
Otherwise, I do it from
I'd like to present to you how to manage the tuberosities in reversal arthroplasty for 4-part fracture. This is a 4-part fracture. The prosthesis is in place already. It has been fixed by cement. And now I'm placing loop sutures in the infraspinatus. You see they are green, same colors, and 2 other sutures are placed in the teres minor, and they are green and white. We cut the needle of one of those loop sutures and we keep the needle of the other one because we will have to pass around both tuberosities after. You see, we use a clamp to make sure we don't mess up all the sutures. And you see the green are at the upper part and the white and green are at the lower part of the posterior cuff. Now we place 2 sutures, 2 loop sutures in the diaphysis, you see, before we put the prosthesis, of course, and we keep the needle on those white sutures because they will be used to do the tension band repair. Now we do the lasso maneuver. We pass the 4 horizontal sutures around the neck of the prosthesis and we reduce the prosthesis. We make sure we separate the upper green and the lower white sutures, in order to have no tangle of the sutures, and we tight what we call the Nice knot, which is very easy to do, as you can see. And we start with the 2 horizontal cerclage where we don't have the needle on those sutures, and we make, you see, a square knot, and we pass the 3 strands in the loop. This is a sliding locking knot called the Nice knot. So now there are 2 cerclages ready to go. We take a grasper, non-aggressive grasper, to bring the tuberosity on the lateral side of the prosthesis. This is a specific prosthesis designed for fracture, you see. And this is the first cerclage which passes around the prosthesis and around the greater tuberosity. This is the lower one with the suture pass in the teres minor. We start with the lower one because we don't want to lower the greater tuberosity. It's at the right spot, so we want to keep it at the right spot. Now we tight the second horizontal cerclage, as you can see, which is the highest one. And after we tie the Nice knot, we add additional half inches. That's done. The greater tuberosity is fixed now around the prosthesis. So we have the 2 remaining horizontal sutures where we have kept the needle, and we pass from inside outside through the subscapularis anteriorly. Here we go. The green and white suture, and we cut the needle. So now we again tight the locking, sliding locking knot, the Nice knot, for the 2 cerclages. So you see the first 2 cerclages were passing around the prosthesis and only around the greater tuberosity. These other 2 horizontal cerclages are passing around both tuberosities and around the prosthesis, of course. So we readjust the lesser tuberosity with the greater tuberosity, and we fix them with a clamp, as you can see, a bone clamp. And then we can tight the 2 horizontal cerclages, the upper one which is green and the lower one which is green and white. So now we have 4 cerclages, 4 horizontal cerclages done, 2 around the greater tuberosity alone, and 2 around both tuberosities. Here we go. So this is very solid already because there is no pulling possible of the tuberosities, and it's like a cuff repair. Now we have the 2 white sutures in the diaphysis, you see, and we pass the first one through the subscapularis tendon in the front. We cut the needle, and we tie the Nice knot again. And we're gonna use the second one to pass through the infraspinatus tendon. So these are vertical sutures which are used to neutralize the construct. So you see, this is done. We are past here. We cut the needle. We tie the Nice knot again. So it's very reproducible because we do always the same thing, and all the fellows are able to do this repair of the tuberosities. So we adjust the tension. Of course, don't over tension, otherwise you will displace the tuberosities. And when you're happy, you add some additional half inches. That's the first tension band suture in the front. Now the second tension band suture in the back. So you see you have 4 horizontal cerclages and 2 vertical tension band sutures, and this is a very strong construct. So I think it's very important to understand this concept. Thank you very much for your attention.
Okay, thank you for the presentation. And the next presentation is about revision in anatomic shoulder arthroplasty to reverse shoulder arthroplasty. Professor O, please.
Good afternoon. Incidence of primary and revision arthroplasty increased exponentially during last decade in terms of number and cost. Soft tissue current adhesion and bone defect makes a revision RTSA difficult. Even though 10-year survival rate of RTSA is good, revision RTSA has inferior clinical outcomes with a lot of the complications. Glenoid loosening is most common cause of revision. So it's better to have a really aggressive systemic approach to find out the cause of the failure. It's better to consider patient factors, anatomical factors including bone and soft tissue balancing, and also implant factors of pre-existing implants and revision implants. There are several scenarios of revision RTSA from anatomical TSA. Technical errors are most common cause of pain without symptom-free intervals because of the prosthetic fracture or malpositioning or poor-sized implants cause instability. Overstuffing is common cause of rotator cuff failure that cause posterior superior cuff tear, including 70% of anatomical TSA after 10 years of implantation. And also subscap tear failures are found about 50%. Humerus loosening is not the common cause of ATSA, but glenoid loosening is very common cause of revision of anatomical TSA, and radiological loosening precedes the symptomatic loosening several years. Let's talk about glenoid revision first. As you know, the glenoid revision includes the component removal, bone graft replantation, and is related to severe glenoid bone defect. There are several options, and we have already discussed before and later. So we can do one-stage bone graft. But for these patients, 4 centimeters of glenoid defect, so I decided to go 2-stage bone graft. And this patient shows the eccentric glenoid bone defect, so I did some bone graft with augmented base plate for this bone defect. And next is humerus revision. Most cases, stem is not the cause of revision of ATSA because it's well-fixed humerus stem. There are several procedures for taking out the stem: longitudinal split, anterior window, medial window, and vascularized osteotomies, and router bit extractions. These procedures are technically demanding, but the clinical outcomes are favorable. We have to think about several things for the revision stem. It should not be long. This small lady, I did the shortest revision stem for this lady. Patient complained the elbow pain. So I have to remove I have to open the elbow and I have to remove the stem. So revision stem should not be long. Mayo Group also published the papers of this revision to short stem is reasonable options, and we can preserve the bone stocks, and they provided the adequate stability and high rates of humeral component ingrowth. And also, stemless ATSA is useful in terms of revision because we can use standard stem after taking out the stemless stem. Like these patients. Because most of the companies provided the modular stem system for revision. So a lot of papers already presented that the usefulness of conversion, the modular stem for the conversion of RTSA. But there's a key is the convertible glenoid components. The first step, the first generation of metallic glenoid in several years, but first generation were the withdrawn from the market because of the glenoid wear. But second generation of convertible metallic glenoid is favorable because of the poly development and porous coated base plate. So this patient has the anatomical TSA with convertible glenoid with nanostem, but show the subscap failure. So taking out the humeral stem is not that easy, but it's easy compared to whole taking out the whole this stem. So we better to only it's the taking out the glenoid component, humeral head component is a little bit careful because of the taking out all the nanostem, but finally I did it. And glenoid component taking out is really easy. Poly can be easily removed from the base plate, and we can check the stability of the base plate, and insert the glenosphere, and insert the humeral tray, and that's all. It's easy. So post-operatively, 3 years later, patient is happy with this conversion, easy conversion. My tips for RTSA from ATSA, for glenoid size, we better to check the amount of strut bone graft, and I'd better to like to use, in case of the bone graft, I like to use parathyroid hormone injection for 3 months for the bone healing. For the glenoid side and for the humeral side, humeral window with sufficient length is necessary, and we'd better to consider the short stem and modular options with cement within cement technique. RTSA conversion from ATSA, we'd better to have modular options for humeral side as well as the glenoid side. So let's keep the principles. Select the proper strategy and find out the cause of the revision. It's better to evaluate the soft tissue and bone and stability of pre-existing implants. And it's better to consider the shoulder is not weight-bearing joint. So we have various implant options. So stay calm and be patient. Good sleep and good temper in the operating room, and keep the principles and fix the cause. Thank you very much for your attention. Okay, let's move to the next speaker, Dr. Itamura. He will talk about the custom glenoid component for massive glenoid bone loss.
Thank you, Giuseppe and John, for allowing me to speak here, and thanks, Dr. O and Dr. Torello. I'm going to present my 2-year follow-up with the VRS implant. I have no financial interest with Zimmer Biomet and my disclosure on the Academy website. So when we talk about glenoid wear or bone loss, obviously Gilles and Suvero's classification for anatomic, for primaries are helpful, but when we talk about revisions, especially the combined defects, Antunes classification and Jerry Williams and Joe Ionati's classification can be very important. Antunes classification was designed to classify the bone after glenoid implant removal, and obviously the severe and the combined are the more tricky ones. I think Jerry and Joe's classification is actually nice if you're publishing papers. So as Tom was saying, as far as what are our options if you have glenoid bone loss, you can use bone. So if a case of primary allograft is useful for revisions. The distal clavicle is nice. You can keep the deformity, or you can use metal augmentations, either off the shelf or PSIs. Joe Ionati published his results. Actually, a lot of complications. However, 80% were able to be revised to reverse with sufficient bone for hardware. Pascal and Gilles have popularized the bio-RSA. Bateman talked about the femoral neck as a nice substitute. Unfortunately, it was only a 1-year follow-up, but this is a preliminary study converting non-contained to contained defects. Here's one of my cases, a woman with pretty severe bone loss. This is her CT scan. You can see almost zero bone. I tried allograft, fixed with multiple screws using the alternate center line. And of course, she got cancer and she failed. At a second case, after this, I gave up with allografts. So for me, I didn't want to get burned multiple times, and our president said this. So my evolution is, this is an 80-year-old stuntman. He had a type C glenoid with hemiarthroplasty with the Artex Universe implant. I removed the implant, put a spacer. Of course, at my explant, half of this culture positive for Cutibacterium acne. So this is his preoperative radiographs. At least for me, the Arthrex stem comes out easily if you use this AccuDriver that Evan Lederman told me about. So it makes this implant easy to remove. Here's the spacer I made. I made a cage. This was 10 years ago with a company called 4Webs. They made titanium trusses, which were 3D printed. And I used the Tournier implant within that. So here's what the trial looks like. Here's the implant filled with DBM. Here's what it looked like at implant. Here's his 10-year radiographs, and here's his function. So this was my first cage. So at least the VRS was published by Berger and Craig and Petrigliano in 2014. The vault reconstruction system design process begins with the placement of the comprehensive mini base plate and placement of screw trajectories for bone purchase based on the surgeon's anatomy and surgeon's preference. They use Friedman's line to target 0 version and 10 degrees of inferior inclination. We published our results in 2020, 18 patients, and we had no complications related to the glenoid, significant improvements in all metrics, and no notching. Murthy published his 3-center results, 12 patients at 2 years, no complications. Giuseppe published their result, 2-year follow-up using the Lima implant, improvement in pros and range of motion. So here's my data. We have 59 patients, 62 shoulders. Of those 62 patients, 15 were lost for follow-up, 2 died, and 6 were revised with 2 infections were deleted from the study. So the cohort was 47 patients, so average follow-up a little over 3 years. For the primaries, basically I used Blueprint software, and if they were unable to be even massive bone loss, so I decided not to use bio, but there were 19 patients, average age of 70 years. For my revisions, their average age of 65 years, or 28 patients, an average of 2.43 surgeries prior to me taking them on, and all had combined uncontained defects. So the total results we had for the whole cohort, all outcome measures were improved for primary and reverse. The outcome measures were all statistically improved. Of course, we did have complications. Primary, we had a PE and a greater tuberosity fracture, but the revisions here are our complications. We had 1 glenoid failure due to probably overlateralization. And this is a patient that showed up in the emergency room in South Florida with his implant sticking out of his skin. So obviously he was a failure. So here's one of my cases, 50-year-old guy, schizophrenic. He had a hemiarthroplasty, complicated by rotator cuff rupture. He had an aortic valve replacement on Coumadin, and he was in a workers' comp case. So here's his preoperative x-ray. You can see he is, but here's his, here's his model. You can see he's lost a significant amount of bone. Because he had a hemiarthroplasty, my plan was a single-stage revision. And here's the plan from the manufacturer. And the silver is the vault reconstruction system. They give you a model so you can kind of do proprioceptive modeling and practicing. And this is what the implant looks like on the model. Here's his bone defect. Here's his intraoperative fluoral. And here's his postoperative radiographs. He's at almost 5 years now. He was in Montana, so I had to do a Zoom interview, but here's his motion. And he's actually very happy. So in summary, I think the VRS provides good options for patients who have significant bone loss. In this study, we had 1 out of 62 with glenoid failure rate. Probably shouldn't have used a lateralized glenosphere. I've done 150 cases now using the VRS, and we had 3 complications. Usually, because there's a glenoid component, I do a 2-stage reconstruction for accuracy of the CT scan. Obviously, this does increase the cost depending on your hospital negotiated rates. Once again, thank you for your invitation to present my data. Thank you.
Thank you, John.
Thank you.
Next topic is management of severe humeral bone loss from Francisco Sosa from Santiago.
Hello, everybody. Thank you. Let me just put my presentation up. All right. Can you see it?
Yes. Yes. But it is a different monitor.
Can you see it now?
Yeah, we just need presentation mode.
All right.
There you go.
All right. So thank you very much for the invitation. And I think this is an important topic. We have the humeral bone loss and revision arthroplasty. I'm going to go through the problems, how to assess them, and how to manage them. So basically, when we have low boss problems, we lose tendon insertions. So the rotator cuff and the rest of the external rotators and the deltoid might be compromised. We might have a deltoid tension wraparound effect altered. We might have loss of space, dead space, and obviously that might compromise the stability of our construct. So when we access bone, we need to be very careful because we can go too short and have a recurrent instability. And if we go too long, we might have excess problems. So it's very important to do our pre-op evaluation and be sure that we're going to have all our instruments available for revision. So there's been numerous intent to do classifications in order to communicate properly between us. And we have the latest attempt to that with the FAIRS. But definitely this still is a consensus method and we still have long ways to go. So what are the options that we have available now? We can go to standard stems when it's appropriate and it's available. But we have sometimes a lot of bone deficit that we have to think something else has been done. So we can go either to an APC or a modular segmental prosthesis with metal. So when we have standard stems, if the stability is appropriate and we can have that right height, we can have probably a bone that we can augment. Sometimes we can grow in the humeral tray. Sometimes we can do cement on cement that is being popularized, and we know that we have good results. And usually we can keep using our revision with shorter stems. We can cheat at the glenoid. We know that by doing the glenoid component as low as possible and by using a bigger head, we can grow also by using a thicker implant. But sometimes we get stuck in this gray area, depending on the size of the patient, between 45 to 50 millimeters of bone deficit. So that's where we have to think about what we're going to do next. Either we're going to do an APC or we're going to go to metal. So the APC, well, it recuperates bone volume. It has the availability of have soft tissue attachments. We can reduce the torque and we can control it better. It's demanding though. It can have its own problems, non-union, bone resorption, cost and infection. And obviously some places and some countries it's not available. So this is an example. We have to think about what is the best way to do the osteotomy. We can go through a flat osteotomy or a step osteotomy. Those things are important so we can have the best compression plating and have the best incorporation of this bone. And obviously the soft tissue attachments might be helpful. It's an example of Mayo Clinic's patient where the APC is being put. Sometimes it's important to have a lot of technical issues to do this right and properly and not have any competition between the stem and the screws. So basically, compression plating can be obtained, and that's key. So we know some of the early results of APC. This is Mayo Clinic's results. And obviously, as every revision, we have high rates of complications. But modular construction might be easier, might be more versatile. Trialing is easier to do. We avoid the graft issues. Costs might be less. But still, we have soft tissue issues. Tendon to metal healing is not being really understood. And obviously, there's some issues like torsion control. Soft tissue attachments, we know we can use tendon to metal interfaces, and probably with this ingrowth to plasma spray, it might help. And the torsion control, there's been numerous attempts in the industry, either using cement, plasma spray, flanges, screws, or anti-rotational spikes that might help. And for sure, we still don't know the body to stem ratio that will give us the best stem stability and avoid stem fractures that might be a catastrophe, like in this case. So as we grow, we can grow by millimeters from the humeral head. This is in our lab, and we can see how we can grow by centimeters in the humeral side. Our experience has been mainly in humeral cases. We don't have a lot of experience. Definitely still high in complications. This is one of the first ones we did 10 years ago in a humeral case where we had 10 centimeters of resection. We were able to reattach the muscle tendon with the bone to metal and soft tissue to metal in reconstruction. This is results at 10 years. The patient unfortunately died 6 months ago. This is another example in our case studies where we had a 2-stage revision, and this is the result that we obtained at 5 years. So obviously, by working with the tumoral guys, this is our most of experience. 80% of our cases are in this setting. And obviously, this is a completely different patient. Most of these channels and diaphyses have not been compromised with previous surgeries. That might make a big difference. So we don't still know the actual risk factors. Primary is revision. We know that revision has a higher tendency of complications. How many surgeries does that affect the biology of the diaphysis? And obviously the host, the patient itself, what the clinical status, the resection level, and if cement is the way to go. So in summary, this is a very challenging problem. We have to evaluate bone deficiency, understand the bone deficit issues. It's key to understand the system that you use to gain length. You have to decide what's a great area for you to avoid these complications, and decides if it's better for you for an APC or metal to use. Be prepared, as they always been saying during the whole length of these talks, and probably learn from your tumoral surgery in my help. So thank you very much, John and Giuseppe, for this invitation.
Thank you. The final talk of the session and this program is the Neurological Complication in Shoulder Arthroplasty by Karl Weiser from Switzerland.
Yeah, thanks a lot. I think it's easiest if you... It's a great honor to be part of this online symposium. I would really like to thank the chairman, Dr. Porcellini and Dr. Sperling, for conducting such a nice meeting and for including me to this meeting. I was asked to talk about neurologic complications in shoulder arthroplasty, which can be a truly devastating complication, as we all know. Here you see my disclosures. They are actually not really relevant for this talk. So complications in reverse total shoulder arthroplasties are numerous and diverse, with an overall complication rate ranging between 5 to almost 70%. Neurological complications in anatomic shoulder arthroplasty has been reported to be between 1 and 4%. However, the neurologic complications after reverse total shoulder arthroplasty remains underreported. That's the reason why Dr. Ruby performed a detailed analysis of iatrogenic nerve injuries in our primary and revision reverse shoulder arthroplasty cases and published this last year. A retrospective review of our institution's internal reverse total shoulder arthroplasty database from September 2005 to December 2019 identified a total number of 34 cases, which equals 2.6% of the 1,309 patients which were available for this analysis. We had 2.5% of nerve injuries in the primary cases and 3.2% of nerve injuries in revision cases. However, this difference did not reach statistical significance. If we characterize or break down the different lesions, we saw that damage to major terminal nerves occurred in 21 patients, which equals 62% of these cases, whereas a lesion at the brachial plexus, either at the trunk or cord level, was diagnosed in the other 38% of the cases. Isolated axillary nerve palsy was present in 7 patients and combined with injuries to other terminal nerves in another 3 cases. The axillary nerve was therefore affected in 29% of these patients. Deltoid muscle strength was additionally compromised in 9 patients with plexus lesions, therefore resulting in various degrees of deltoid paresis in overall 56% of these patients. The suprascapular nerve was affected in 9%, the ulnar nerve in 15%, and the radial nerve in another 12% of the cases. In 4 of the 34 cases, nerve revision or reconstructive surgery was necessary. In 2 cases, the axillary nerve was either sutured end-to-end or reconstructed using an interpositional graft. One radial nerve needed neurolysis, and another radial nerve injury was treated by a tendon transfer. 30 of the 34 cases were treated conservatively, leading to a full motoric recovery in 55% and a full sensory recovery in 41% of the cases. And here you see the cases with deltoid muscle affection. 13 of the 19 patients had a good recovery and a mean flexion of 120 degrees. 4 patients had a poor recovery with a mean flexion of only 30 degrees. The risk factor analysis showed that neither gender, BMI, or a history of tobacco use correlated with the occurrence of iatrogenic nerve injury. However, younger age, longer surgical time, and a higher number of previous surgeries were found to be statistically significant risk factors to sustain such an iatrogenic nerve injury. And finally, neither the surgeon's experience, according to the educational level, nor the placement of an interscalene catheter using ropivacaine had a significant influence on the occurrence of an iatrogenic nerve injury. So in summary, our analysis revealed a rate of iatrogenic nerve injuries in 2.5% in primary and 3.2% in reverse total shoulder arthroplasties. Deltoid muscle strength was compromised in 56% of these cases, which was related to either an axillary nerve or a plexus lesion. We observed a full motoric recovery in 55% and a full sensory recovery in 41% of these cases. Identified risk factors for nerve injury were higher number of previous surgeries, younger patient's age, and longer operative time. Ian Flatto and his colleagues published this top 5 rules to avoid neurovascular injury during total shoulder arthroplasty, which you can see here. However, due to shortage of time, I cannot go into this in detail right now. Thank you very much for your attention.
Thank you, Carl.
Okay, we have time for a little discussion or not?
Yes.
We have
5 minutes for some discussion, please.
Okay.
5-10 minutes, please.
Okay, because there are about question about from the audience. I think is nice if we can answer to question. The first question to Professor Bolo is: do you consider your suture technique only if the bone fragments are big? Often the bone fragments are small and the quality is poor.
No, I think it's a standardized technique, suturing technique, and I use it for all cases. The sutures are not passing through the pieces of bone. The sutures are passing through the tendons. And if the piece of greater tuberosity, for instance, is very thin, which can happen, it's very important to use the bone graft from the humeral head to increase the cancerous bone at this level. What is very important is to realize that the greater tuberosity fragment should be lateral to the prosthesis and not posterior to the prosthesis. I think that's a big mistake that some young surgeons may do some at the beginning of their experience.
And my question is different. If you have a possibility to close the upper part of the cuff, you close or no?
That's a very good question. In the sawbone model, I didn't have the supraspinatus tendon, but in reality today, since at least 4 or 5 years, I keep all the cuff, including the supraspinatus, which means even though it's a reverse prosthesis, I don't reject the supraspinatus. I keep it and I reattach it with the rest of the cuff muscles and tendons.
Okay. Any questions?
Francisco, what is your indication of what's your choice between a PC and megaprothesis? What is your reference?
Well, our preference is metal, just because we don't have availability of bone allografts. We have to import them, so it's technically very difficult to get it in Chile. That's why we go through metal.
Okay.
John, I have two questions to John Itamura. Ciao. John, the problem of revision is the quality of bone, because you have two failure, probably not only for the bone from the graft, but for stability of the peg, the central peg. What do you think about the original glenoid? Second question, I revise my case. Of course, the patient are happy about the pain, but not for the function. It's worthwhile to do this surgery for the cost, just for the pain?
Well, great questions, Giuseppe. So the failures I think that we've had with the VRS is when there's a significant superior bone loss, and I think there's just too much torque on the glenoid component. And if you over-lateralize, it even increases that torque. My goal always is for pain relief. If they have good function, I will just I would try to talk them out of surgery. It's amazing in the 2 stages that if you get rid of a bad implant or infections, you can put a spacer in, and as long as there's some stability, those patients will actually be happy. You don't have to go to a second stage. But at least for me, I haven't started doing the lower trap transfers in combination with APCs in some of these revisions, and that may be my next journey, but it's a lot of surgery.
John, can I ask you a question? You have presented two kind of patient-specific augment. One was a full metal, and the other one was a kind of cage. Is the cage the second, the last version of your system, or and do you put autograft or allograft in this cage?
So the cage actually, Pascal, was Steve Block, who used to work with Tournier. He had a company called 4Web down in the southern U.S., and that was a custom truss that was printed. He said to pack it with bone graft because they used it with tibial defects. So that's much harder because you have to use existing implants, and so it's harder to get the bone. So I think the VRS is much easier to use, and it's actually probably cheaper. But that was my first iteration. I did about 6 of those, Pascal.
So now it's full metal.
Correct.
Okay.
Do you have any experience on musculocutaneous nerve palsy? Actually, I have several cases of, thanks to my strong and aggressive residents, that's the musculocutaneous nerve palsy happens. So what do you think about it? Any report on instance and recovery about that?
Very, very rare cases. We have, I don't know, in our series, maybe 3 or 4 of them. Most of them recovered. I think it's traction injury due to the medial placed humeral retractors, or lung and back retractors, actually. But nothing specific to add here.
John,
Sorry.
Yeah.
Carl,
go
I
on.
have a question about revision case. What do you think about prevention of neurological complication with neurolysis of plexus before implantation of reverse? It is a good idea to avoid the complication, or just is over treatment?
So personally, I think it might be over treatment to really make your full plexus release in a revision setting. I think what you can consider is if you have infection and need a lot of debridement to look at the nerves which are in your field, like the axillary nerve, especially the axillary nerve. But I think I would not go medial to the concha tenor and release the plexus. Do you have an experience with that, Giuseppe?
Just in 1-2 cases, because I have a good luck situation, because I work with a neurosurgeon with the peripheral, and if you perform EMG intraoperative and there is a big, not a good mobility of plexus, probably it's worthwhile to release.
And do you perform a coracoid osteotomy and then refix the coracoid, because then you have a lot of tension on it with the reverse? I would be afraid of failure of the coracoid.
No, it's a neurosurgeon go medial to conjoint tendon, just to release in the medial part.
Okay.
Well, I think with Giuseppe, with that, I think we'll wrap up the session in the meeting. First, I'd like to thank so much our wonderful faculty. Greatly appreciate all your contributions, terrific lectures, and greatly enjoyed the discussion. We'd like to thank the participants as well. Really enjoyed this today. Like to remind everyone, we're excited about having this meeting in person. We were in Venice last year, which was spectacular. And then October 2024, nothing better than beautiful October weather in Florence, Italy. We look forward to inviting you there. So once again, thank you so much to everyone for their participation today. Greatly appreciate it.
Thank you, John, for your incredible work.
Thank you.
Thank you, Giuseppe.
Thank you. Thank you very much. Bye.
And John, it's easy to work with you because you seem a Swiss watch in perfect time in every section.
We value and appreciate everyone's time. Thank you so much. Have a great day.
Thank you.
Thank you.
Have a nice weekend.
Bye.